We will try to finish 3 vitamins, and all the 3 are very important. Out of these 3 vitamins, 2 vitamins are important for long question. One is this folic acid, another is vitamin C. Why don't you all sit this side? Can you see from there? Fine. So, folic acid, the name has evolved from folic, for folium means leaf. It is available in green leafy vegetables mostly, and fresh. If it is not fresh, then folic acid is not available because it gets oxidized very easily. Now see, the chemical compound is pteroyl monoglutamate. It can go up to pentaglutamate. The pteroyl monoglutamate contains these 3 compounds: pteridine ring, para-aminobenzoic acid, and glutamic acid. Pteridine ring, para-aminobenzoic acid, and glutamic acid. Folic acid composition is very, very important. Pteridine ring, PABA, and glutamic acid. Glutamic acid residues numbers may vary from 1 to 5. From monoglutamate to pentaglutamate, it might go as high as pentaglutamate. Okay. Now, usually the pentaglutamate form is storage form, and when it comes for coenzyme action, it becomes monoglutamate form. Fine. Now, why this is important? This structure is important because we cannot synthesize folic acid. Human being cannot synthesize folic acid, but bacteria can. Now, there are certain drugs called sulfur drugs. Sulfur drugs which are used against bacteria, correct? What these sulfur drugs do? The sulfur drugs mimic this compound. PABA. During the biosynthesis pathway of folic acid, it mimics sulfur drugs, mimics sulfanilamide, it mimics PABA, and it replaces PABA in the synthetic pathway, and thereby it stops, it inhibits the normal biosynthesis of folic acid. Now a bacteria being a unicellular organism, they easily succumb to death due to lack of folic acid. But since we don't have any biosynthetic pathway for folic acid, these sulfur drugs do not harm us. So we can use it as antimicrobial agent or antibacterial agent, sulfanilamide, correct? So remember, and this mechanism of action is based on competitive inhibition. So when it comes for competitive inhibition in enzymatic reaction, this example you can provide. Followed? Now folic acid is very, very important as far as our metabolism is concerned. Now these are the 3 parts of the folic acid group. This is pteridine ring, this is para-aminobenzoic acid, and this is glutamic acid residue, and by amide linkage. Now they exist in coenzyme form, different coenzyme form. The major coenzyme form is tetrahydrofolic acid. See, sulfur drugs blocks here. And can you read it? What is it? এখান থেকে বলো, what is it? বলো, you. Can you read? Stand up. You. The red color girl. Yes. Can you read it? You cannot read it? Why? Can't see. Come this side. Yes. Can you read? Trimethoprim. Good. What is this trimethoprim? Any idea? Quickly. No time. Anyone? Definitely. Correct? This drug, what kind of drug? For what? Treatment of what? The anti-cancer drug. Sit down. So there are 3 anti-cancer drugs I will mention. Methotrexate, aminopterin and trimethoprim. Can you write? You see names? MAT, methotrexate, aminopterin and trimethoprim. These 3 drugs are called anti-folate agents. These 3 drugs, anti-cancer drugs, are called anti-folate agents. These anti-folate agents, they inhibit dihydrofolate reductase enzyme. This step, okay, and thereby they stop regeneration of tetrahydrofolate in our body. They stop regeneration of tetrahydrofolate in our body. Now, folic acid is required for synthesis of DNA. If you go back, nucleic acid metabolism, the de novo synthesis pathway of purine, biosynthetic pathway, it contains 2 steps which require folic acid. Formation of thymidine from uracil requires tetrahydrofolic acid. So all these are not possible without folic acid. Now folic acid is required for growing fetus, for development of brain, and it is also required by the uncontrolled cancer cells, because cancer cell, they grow in number as well as in size. So when they grow in number, they require more folic acid for production of more nucleic acid. Now when we stop regeneration of tetrahydrofolate and their associated coenzyme forms required for biosynthesis of purine nucleotide, we actually stop the process of nucleic acid synthesis. Now which cell will be harmed? The cell which turn over very rapidly. Which cell will turn over rapidly? Our normal body cells except blood producing tissue and the GI mucosal cells. Cancerous cells will succumb to death. So along with cancerous cell, the GI mucosal cell, hair follicular cell, blood producing tissue, they also will be dying with these kind of drugs. So it is a collateral damage. We want to kill the cancer cells, but our normal hair follicular cells, they also turnover number is very high, hair follicular cells. So that's why you see after an anti-cancer treatment, people lose hair. And after some days again it will regain. Okay. So this cancer therapy, then they have sprue kind of thing, IBS, because of loss of GI mucosal cell. And they have anemia. Why? Because blood producing cells are affected. So they have to be given what? Blood transfusion or nutrient transfusion, the vitamin transfusion, as well as the nutrients which is required, which is not possible to be absorbed because of the damage of the GI mucosal cells. Correct? Clear? So folic acid, anti-folate agents are MAT, M-A-T. They inhibit dihydrofolate reagent, the dihydrofolate reductase, and thereby stop the production of or regeneration of tetrahydrofolic acid. The tetrahydrofolic acid is a coenzyme form of folic acid required in the biosynthesis of many of the nucleotides. Now you have to remember the names of these coenzyme forms. Enumerate the different coenzyme forms of folic acid. You must be able to name them. Correct? Can you name? Quickly. N5-methyl. Start with N5-methyl. N5-formyl. N5-formyl. N10. N5-formyl THF. N10-formyl THF. N5-formimino THF. N5-N10-methinyl THF. N5-N10-methylene. And N5-methyl THF. Okay. All these are different forms of folic acid coenzymes. Different forms are required in different reactions. Each reaction has been mentioned in this. Now, this is a biosynthetic pathway in microorganisms taking place. Where do you actually, this one is blocked. Okay. We'll move on to next slide. Sources C. Okay. Now these should be very fresh. If you fresh, then it is good. We'll have more about more folic acid. Otherwise, it will be very less. Forget about bioavailability, digestion, not much. Absorption we skip, transport we skip. Just take a photograph of this or try to remember. It is not asked in the examination, this slide, but this will give an idea at how the folic acid is actually absorbed. Dietary folate, see, predominantly as polyglutamate. As I mentioned, the storage form of folic acid is pentaglutamate. So the polyglutamate form we receive from the plants. Then in the intestinal lumen, in the jejunum, see, a part of it is absorbed in the monoglutamate form and part is excreted through feces. Part of it goes to plasma, to liver, systemic circulation, peripheral tissue. It goes to kidney and urine. And this part is mostly monoglutamate form, which is excreted in the urine. And this is excreted in the this thing, it is mostly polyglutamate form. This is the pathway of production of folate. Folate to folate reductase. এটাকে ফোলেট করে দাও, নট ডাইহাইড্রো না, এটা উল্টো দিকে আছে তো। ফোলেট রিডাক্টেজ, ডাইহাইড্রোফোলেট টু 5, 6, 7, 8 টেট্রাহাইড্রোফোলেট রিডাক্টেজ বা ডাইহাইড্রোফোলেট। এটাকে ফোলেট রিডাক্টেজ করো, মেক ইট ফোলেট রিডাক্টেজ অ্যান্ড মেক ইট ডাইহাইড্রোফোলেট, ডিএইচএফ রিডাক্টেজ। ওকে, এটা চেঞ্জ করে নাও। This is folate reductase, this is dihydrofolate reductase. Both require NADPH. Fine? This is important. So methotrexate, aminopterin and trimethoprim, where do they act? In which enzyme? Which step? বলো, তোমাকে বুঝছি, বলো দাও, আগে দাঁড়া, ঘুমিয়ে পড়ছিস নাকি? কি স্কুল বল। মেথোট্রেক্সেট, অ্যামিনোপ্টেরিন, ট্রাইমিথোপ্রিম কোন স্টেপটাকে ইনহিবিট করে? ক্লাসে আছিস, চোখ খোলা মাছ নাকি, ঘুমাচ্ছিস চোখ খুলে? নেক্সট বল, কি বল, শুনছিস না ক্লাসে? তাহলে কি শুনছিস? এই ফার্স্ট বেঞ্চ বল, কোন স্টেপটাকে ইনহিবিট করে? কোন স্টেপটাকে ইনহিবিট করে? মেথোট্রেক্সেট, অ্যামিনোপ্টেরিন আর ট্রাইমিথোপ্রিম। হ্যাঁ, কোন স্টেপটাকে ইনহিবিট করে? এইটাকে না এইটাকে? এই স্টেপটা, এটা এনজাইমের নাম কি? না, এখনই বললাম চেঞ্জ করতে। হ্যাঁ, এবার বল, মেথোট্রেক্সেট, অ্যামিনোপ্টেরিন, ট্রাইমিথোপ্রিম কোন স্টেপটাকে ইনহিবিট করে? ডাইহাইড্রোফোলেট রিডাক্টেজ। বলে দিচ্ছি, বারবার বলছি। এইরকম ভাবে ক্লাসে থাকলে খুব মুশকিল, তাই না? This kind of attendance in the class is very derogatory. Sit down. No use. There is no difference between you and the furniture. Utilize time. Now these are the reactions where folic acid is required. Quickly note down, or whichever way you find better. হয় ছবি তুলবি, নয় লিখে নিবি, আর নয় চুপ করে দাঁড়িয়ে থাকবি, তাই তো? কিছু একটা কর, ডু সামথিং। ইটস এ ওয়ার্কিং ডে, নড়াচড়া কর। Now, can anyone remember this slide? You have to, because this is the only long question you will get. All you have to do is to remember and reproduce this slide in the examination. That's all. That is the only long question from folic acid. Okay. So this is the long answer for the long question. What is this actually? There are different forms of folic acid coenzyme. So this slide shows the interrelation, interconversion of the different forms. Which reactions are involved in the interconversion of these different forms. Right? So actually, see this is this is the pathway which puts a lot of folate in the pool. Then it comes from here also. It comes from here also. Correct? This reaction is very, very important. Because this is a major reaction which replenish. Which one? This one. Which replenish. This is a major reaction. What is the name of the enzyme? Methionine synthase. Methionine synthase. There are only two such enzymes which can convert N5-methyl THF to THF. One of these is methionine synthase, this enzyme. Correct? So N5-methyl THF is converted to THF. And from THF, other things can be formed. Mostly this one. N5, N10, all this. But major reaction is this one. If there is a block here, then the folate pool in the cell will not be replenished. Abar bhorti kora jabe na. So there will be a secondary folate deficiency. Although folate is there in the body, but cell will perceive that folate is deficient. Why? Because the folate pool has not been replenished by N5-methyl conversion from N5-methyl THF. Clear? Now this is very, very important, and this requires vitamin B12. So in case of vitamin B12 deficiency, there will be secondary folate deficiency. There will be secondary folate deficiency, and this is called folate trap. This is called folate trap. Folate is there in our body, but all the folate is trapped in the form of N5-methyl tetrahydrofolic acid. Now, these cannot be converted to folic acid and other forms from folic acid because of lack of B12. So, deficiency of vitamin B12 will produce a secondary deficiency of folic acid. This situation is called folate trap. Folate trap. Take a note of these slides. These will show all the enzymes and the different forms of folic acid which are used in those enzymes as coenzyme. N5-N10 methyl tetrahydrofolic acid is used by these two, serine hydroxymethyl transferase, which converts serine to pyruvate, and thymidylate synthetase, which converts DUMP to DUTP. DUMP to DTMP. UMP to thymidine. N10 formal tetrahydrofolic acid. This is formyl transferase. Glycinamide ribonucleotide transformylase or formyl transferase, where in nucleotide denomosynthesis of nucleic acid, purine biosynthesis pathway. Okay, so all this. Next, we'll go N5-methyl tetrahydrofolic acid. See, one of the enzyme is methionine synthase, another is, what is this? Glycine S-methyl transferase, where যদি পড়ানো হয়নি তোমাদের অ্যামিনো অ্যাসিড না। আচ্ছা, ফর্মিমিনো গেল। Now those who cannot remember that big diagram, for them this one. Now everyone is smiling. Okay, if you cannot remember the big one, the long answer for the long question, remember the medium answer for the long question. So what you will get? You will get medium marks. Okay, taken down. দেখা আছে? আচ্ছা, সময় নেই। Vitamins and minerals always pick and choose what to read, what not. Long questions will be asked only from this. One is this interconversion of folic acid. This is called one carbon metabolism. That whole slide is designated as one carbon metabolism. Describe one carbon metabolism. The question comes. Nothing. Just draw the slide with all the reactions. That's all. Need not to write even a single sentence. What you want to convey, we will understand. Whether you have understood or not, that is another question. But we will understand that you understood. But that doesn't mean that you have understood. You have just memorized it and vomited rightly. Then you can forget it. Unless you again come back to biochemistry in from some other area. Otherwise, it's not required. Fine. This is a Figlu excretion test. All these things will be taught during amino acid metabolism. Folate deficiency. How to assess folate deficiency? How to assess folate deficiency? How to assess our body is deficient in folic acid? Long back, nowadays we can measure directly, but long back there was no such measuring method. So that time they used to perform this test. Now it is obsolete. It is called Figlu excretion test. Figlu excretion test. Formiminoglutamate. Figlu full name is formiminoglutamate. Formiminoglutamate. So patient is given high dose of histidine and the urine with Figlu appears. Means what? Due to folate deficiency, all of the Figlu cannot be converted to glutamate. So they get excreted due to excess of Figlu in the blood. So if they excrete Figlu upon feeding overload, a heavy load of histidine, then the patient is suffering from folate deficiency. Clear? This is called Figlu excretion test. These are the different reactions. Now this one you can remember. This one shows the interrelation between B12 and tetrahydrofolate. The interrelation between B12 and tetrahydrofolate. See the reaction here. Methionine is converted to SAM, S-adenosine methionine. Then it is converted to S-adenosine homocysteine. Then from S-adenosine homocysteine to homocysteine. Then homocysteine to it goes back to methionine. Here it requires methionine synthase enzyme, which requires vitamin B12 as coenzyme. This is methylcobalamin. Methylcobalamin gives out its methyl group and becomes cobalamin, free cobalamin. The cobalamin then takes up another methyl group from N5-methyl tetrahydrofolic acid, and N5-methyl tetrahydrofolic acid convert to tetrahydrofolic acid. This tetrahydrofolic acid then convert to N5-N10-methylene tetrahydrofolic acid, and from there other forms are synthesized. So if there is a block here, why? Because of lack of methylcobalamin. Then what will happen? The folic acid will not be converted to here. So it will be folate trap. Okay? So this is how actually it is not folate which donates the methyl group. It is a methylcobalamin which donates the methyl group for methionine synthesis. Correct? But in the reaction, what you have written? N5-methyl tetrahydrofolic acid, arrow tetrahydrofolic acid. Why? Because in between the methylcobalamin and cobalamin, they get interconverted. So we omit that step. Means what? X plus A is equal to Z plus A. Means what? If you deduct A from both sides, what will happen? X is equal to Z. Right? Like that. So that's why we do not write B12 while writing. Only just mention between B12 is required. But this is how it is required. Now, deficiency manifestation. Very, very important. Deficiency manifestation of folic acid. Very, very important. Megaloblastic anemia. Erythrocytes are larger with nucleus. Megaloblastic anemia. Cancer. Folate antagonists. Means in case of cancer there is folate deficiency. In case of folate deficiency there is megaloblastic anemia. In case of cancer there is folate deficiency. Why? Because cancer cell will utilize folic acid for overproduction of nucleic acid. It is growing rapidly. Folate antagonist. To treat cancer you are given folate antagonist. So folic acid again further will be deficient in the body. Pregnancy and birth defect. Pregnancy overutilization, increased utilization. Fetus plus mama, both are having folic acid. So requirement is high. So that's why Government of India has made a rule that iron and folic acid tablet should be given to all pregnant ladies throughout the country free of cost. Because that is the only largest cause of fetal death, iron and folate deficiency. Some drugs also intercepts. Now, what are the defects we have? The neural tube. If you have started embryology, you started? Have you heard this word neural tube? Huh? In the initial stage of formation of embryo, the CNS is formed in the form of a neural tube. The neural tube starts from the first part, upper part is forms brain and lower part forms the end of the spinal cord, coccyx. Now, this region shows spinal bifida. Means the spinal cord will be divided into half. Spinal bifida. So, folate deficiency causes all sorts of disorders related to brain and CNS, nervous system synthesis. Spinal bifida. Now, what is this? Anencephaly. Anencephaly means the brain is absent. No brain. The fetus will take birth without brain. Microcephaly, small brain. Hydrocephaly, large. Microcephaly, small brain. Anencephaly, no brain. Usually they die. They cannot survive. Microcephaly, they survive but with very low IQ. Okay, move on to the next slide. These are predisposing factors for folate deficiency. Just go through quickly, and if you have any question, you ask me. Any question? Vitamin B12. There are 4 forms of vitamin B12. B12 chemical name is cobalamins. Cobalamins. No E. NS. COBALIMINS. Cobalamins. Okay. No E. Cobalamin. Okay. Different forms are these. Cyanocobalamin, hydroxycobalamin, 5' adenosine cobalamin and methylcobalamin. Each one has got discrete function. Each one has got discrete function. They contain scorin ring. The inner ring is scorin ring. Like for hemoglobin, they contain heme. Heme contains porphyrin ring. Cobalamin contains scorin ring. Okay, it's somewhat similar to porphyrin ring, but except few differences are there. And the central ion is different. In heme it is iron, here it is CO means cobalt. See, this cobalt, all are same almost except this one. It is directly linked. In porphyrin there is methynyl bridge. Sources, do you find any plant product here? So this is, you have to remember, mostly B12 is we receive from animal sources. Mostly B12 we receive from animal sources. And what about the vegans? Vegetarians? Do they die? Never. Then from where do they get it? Anyone? Anyone vegan here? Anyone vegan? They have to take fermented product. When you ferment milk, কি বলছিস? হ্যাঁ? শুনতে পাচ্ছি না বাবা? জোরে বল, বুঝতে পারছি। আচ্ছা, he is absent. Next time when you talk, dear son, next time when you talk to a teacher, please mind to stand up. Okay? So, the vegans, the vegetarians, they receive B12 from the fermented product of milk. From the fermented product of milk. Means the curdling process occurs due to bacteria. So, the curd contains bacteria. Even if you pasteurize the curd, the bacterial body leftover still remains in the curd. So, from there they receive the required B12. Clear? Moreover, our small intestine, large intestine contains some bacteria which produce B12. But large intestine, whatever B12 they produce, it cannot be utilized by us. Why? Because B12 absorption is very unique, unlike any other vitamins. What is another name of B12? Cassell's extrinsic factor. We need Cassell's intrinsic factor to be conjugated with Cassell's extrinsic factor prior to get it absorbed. Now what happens in B12 deficiency? Macrocytic anemia, neurocytic symptoms in elderly patients, and chromosome damage. The scientific name, ascorbic acid. Okay, so it is existing in two forms, ascorbate and dehydroascorbate. Dehydroascorbate means this is oxidized form and this is reduced form. Clear? Now dehydroascorbate and ascorbate both are active coenzyme forms. Both are active coenzyme forms. Some reactions require ascorbate and it gets converted to dehydroascorbate. Some reaction requires dehydroascorbate and in turn it gets converted to ascorbate. Fine? So this is how they interchange. Now this vitamin C by nature is carbohydrate. Okay? It is 6 carbon containing compound. What does it do? It has reducing property. It can reduce Benedict's reagent. Now, if a person is given heavy dose of vitamin C and next day morning, if you test his urine, it will show Benedict test positive, means red precipitate you will receive with Benedict test with urine. So that will give you a misidea, the misconception that the person is excreting sugar. No, he is not excreting sugar, he is not excreting glucose. He is excreting another reducing substance called ascorbate. In the evening, if you test the same person's urine, it will be normal. Why? Because it is being water soluble, it will be excreted. The excess of vitamin C will be completely excreted. Clear? Now, vitamin C is required, as you know, the deficiency of vitamin C causes a disease called scurvy. From 10th standard or 8th standard you have been studying. Now, what is it actually? Scurvy. What is the role of vitamin C? Vitamin C is used for a particular reaction called hydroxylation. Hydroxylation required vitamin C. Now, what is hydroxylation? The hydroxylation is taken done by a group of enzymes called monooxygenases. They transfer a single oxygen and convert it into hydroxyl group. These monooxygenases, important monooxygenases all are from actually amino acid metabolism. Now, can you remember these 5 enzymes? The first enzyme is required for conversion of phenylalanine to tyrosine. In absence of this enzyme, tyrosine becomes essential. So, instead of having 8, now they will have 9 essential amino acids. But usually in normal person, the phenylalanine is converted to tyrosine by the action of phenylalanine hydroxylase. Now, this reaction requires vitamin C, tyrosinase reaction requires vitamin C. All these are important for production of certain compounds called a deficiency of vitamin C may give rise to lack of synthesis of melanin. PHPP oxidase is another pathway, another enzyme in the same pathway down to tyrosine formation. Prolyl hydroxylase and lysyl hydroxylase are involved in hydroxylation of proline. Hydroxyproline. This is an important post-translational modification taking place in collagen fibers. The collagen fiber contain XY glycine, this kind of repeated trimer amino acid units. Okay. Now X in 33% cases is hydroxyproline and Y is in 33% cases is hydroxylysine. So this hydroxyproline is synthesized, is formed after the synthesis of collagen. That is why it is called post-translational modification. Clear? Lysyl oxidase is another enzyme which converts. So, question may be asked. Yes, there is another enzyme called lysyl hydroxylase also that will convert lysine to hydroxylysine. Okay, I did not write because of repetition. Next important is hydroxylysine to hydroxylysine will be joined like this. 2-hydroxylysine will be joined like this, and this linkage is necessary for cross-linking of neighboring collagen fibers. Collagen is a protein present in our skin. So when we have a cut, the collagen fibers are cut and blood emits. So when blood comes out, after some time the blood stops. Why? Because the collagen again starts synthesizing. And when if they cannot form the network like this, then blood cells will not stop coming out. And for forming this network between two adjacent fibers, vitamin C is required. That's why after surgery, vitamin C is prescribed for quick healing of the surgical wound. But vitamin C is present in very few citrus fruits. Whatever sour is not vitamin C. Vitamin C is sour, but whatever sour is not vitamin C. Okay, so remember these reactions for vitamin C. Fine. Number 2, vitamin C is required for absorption of iron from gut. Absorption of iron from gut, because it is thought that iron is absorbed in ferrous form. Iron is absorbed in ferrous form. So ferric to ferrous. This conversion takes place via vitamin C. Clear? Third point, vitamin C along with, in synchronization with vitamin E, acts as a potent antioxidant. Vitamin C has got sparing effect on vitamin E, as well as vitamin E has got sparing effect on vitamin C. Okay? Vitamin E has got a sparing effect on vitamin E, and vitamin E has got a sparing effect on vitamin C. Vitamin E has antioxidant, function of vitamin C as sparing effect on vitamin E, right? Function of glutathione, everything. Single answer. So vitamin C is required for regeneration of vitamin E. Right? So in absence of vitamin C, what will happen? Vitamin E will be required more. Right? Now what is RDA of vitamin C? Recommended daily allowance. All these whatever I taught, RDA is in milligram 1 to 2, except B12. B12 is again in microgram, 300 microgram, less. Why? Because B12 can be stored in the body. What about this thing? Vitamin C, it is 700 milligram per day. Very high. Very high. And if the individual is a smoker, then it is double the amount. Okay? So if you smoke, you have to take double the amount of the normal required daily allowance of vitamin C. Right? What else? That's all. Now, questions, short questions if you ask. questions from whatever I taught today. Important questions you can get. Describe one carbon metabolism. Describe one carbon metabolism and show the interconversion of different forms of folic acid. What is folate trap? What is Figlu excretion test? What are deficiency manifestation of folic acid? What are deficiency manifestation of folic acid? Then enumerate the functions of vitamin C. Long question. Enumerate the functions of vitamin C. Long question. And it is asked in physiology, absorption of vitamin B12. I deliberately skipped that line, skip that portion because it is taught under physiology. Absorption of vitamin B12 from gut. Okay? Any other test? That's all. That's all. To be sufficient. Okay?
Good morning, everybody. Please. Now today is already your upper limb bones you are studying. Shantanu sir is demonstrating and Ognimita is demonstrating. And now your also dissections have started. Dissection have started. And today we will be discussing palmar fascia. We will be discussing palmar fascia including fibrous flexure sheath of digits. Now, this first two slides, you please concentrate, and this is from Grant's anatomy. And you have to know the skeletal structure of the hand and the bones. Now, you are already have completed the lower limb, foot, and these with the evolution of mankind, the high hand has evolved as a very highly you are going to see in the next corresponding slides that this is an important tool. Everything, every organ, even the little toe is important. You can be without a little toe or a great toe, but little toe it's okay, but great toe, of course, you wear slippers or any chappals, it has some action. Now, if you the carpal bones, 8 in number, are arranged in a proximal and a distal row, each of 4 bones. Their names express their general appearances. From radial to the other side they are. You see, when you you take a articulated hand today and you just don't have to, of course you have to mug, but if you have this picture in mind and there are 8 bones, proximally 4, distally 4. Now, the proximal row is scaphoid, yes, lunate, triquetral, and pisiform. This is the ulnar and the radius. You think it as carpal bones as cubes. If you see it individually in the skeleton, you will be seeing, बाबू आप गप करने चाहते तो बाहर जाइए. If you are not interested, I'll give the ना आज के हमने आगे ही दी दीची. I get distracted. Personally, I get distracted. I don't know about your friends. এটা যদি রিপিটেডলি বলতে হয় তোমার ভালো আমার ক্লাস ভালো নাও লাগতে পারে. ইউ ক্যান লিভ. একজনও যদি পড়ে থাকবে, কেউ যদি না থাকে আমি 1 ঘন্টা এখানে খালি বকবক করে যাব আমার বেঞ্চগুলোতে. তোমরা আগের দিনও বলেছি যে পরীক্ষা দিয়েছো, যার যা পারফরমেন্স, কাউরির ভালো কাউরির খারাপ সেটা আলাদা বাদ দিয়ে অ্যাভারেজটা কিন্তু খারাপ নয়. অ্যাভারেজ বলছি, অ্যাভারেজটা খারাপ নয়. Now, the distal row, the trapezium, trapezoid, capitate and hamate. You just draw in your notebook and level them. Now, this is the skeleton. Now, here's the radial side, the thumb, the trapezium, scaphoid, lunate, triquetral, pisiform, the ulnar side. This is the carpal bones and their metacarpal bones are here. Now, steps in drawing carpal bones. Now, you can see this, you just draw like this. Simple drawing. This is the radius. This is the ulnar. Now, scaphoid, lunate, triquetral and the pisiform. Similarly, distal row. You can see now, because this skeletal structure you have to know, ought to know the attachment of the palmar aponeurosis and the sheath. If you know this basic, then it will be very easy to correlate and define. Now, these are mnemonics. To save lives, the physician helps create treatment. To save lives, the physician helps create treatment. Now, 1, 2 trapezium. 1 is 2 trapezium. Save is scaphoid. Lives is lunate. Is the 1, 2, 3, 4, 5. Now, 4 is the triquetral. This is the triquetral. And 5 is pisiform. And in the distal row helps hamate. Create is capitate. 7. And treatments, trapezoid. Here, 8th is the trapezoid. Now, this is the basic framework. And if you have this in mind, you can build up the story. Now, thickening of the deep fascia, the flexor retinaculum, palmar aponeurosis, fibrous flexure sheath of the digits. Now we can see the palmar aponeurosis. This is the muscle palmar brevis. This is the flexor retiniculum. Now, flexor retiniculum, what is it? It's a, when you dissect, you will see, when you open, you will see it's a strong fibrous band. Converts anterior concavity of carpus into a tunnel called carpal tunnel. Now, it is a band like this. You can see this, and that is not the now medially attached to pisiform and the hook of the hamate. The pisiform and the hook of the hamate. Laterally attached to tubercle of the scaphoid and the crest of the trapezium. Now, the previous two slides which I had shown, you can build up the story in that form. Now, structures superficial to the flexor retiniculum. These will be the questions. Short notes or describe the palmar fascia or flexor retiniculum and the structures passing below and above and the vessels and nerves related to it. Now the palmaris longus tendon, the palmar cutaneous branches of median and ulnar nerve and vessels. Now superficial palmar branch of radial artery. Structures deep to the flexor retiniculum. You will all see it in the dissections. And this is the median nerve, structures deep to the flexor retiniculum. Median nerve, flexor pollicis longus tendon, flexor digitorum profundus tendon, flexor digitorum superficial tendon, flexor carpi radialis tendon. These are important because see one thing, if you anytime a cut injury or any injury, naturally you have to give it an emergency. You cannot refer it to a hand surgeon. We don't have, I think we have to count throughout India, I think hardly 50 are there. Now you have to manage it. It is under local anesthesia. If it is a bad state means your infrastructure wise, if you are having no means, at least open up and see what is the state of affairs. And accordingly, if there are too much of bleeding, then the spurted vessels, the radial branch, then you have to stop the bleeding, and that can be all managed under local anesthesia. You have to, and for this, now you will be, the pool of blood will be there, but you take a blood pressure instrument, put the cuff, and you just ask your any assistants to tighten it. Naturally, the blood flow stops. Don't open the valve. Now you swab, clean, and identify the structures. You have, this is a very big, these hands are very prone to injuries. You see motorbike and whatever, day to day, everything, injuries are increasing. Naturally, if it bleeds and succumbs to death or any other complication, then you will be blamed. If no one blames you, don't wait for anyone blaming you. This can be managed in a primary health care if you have at least the sutures and a blood pressure instrument and few small, it might not be for microstructures or something, at least you give a chance, say 100 kilometers, 200 kilometers Kolkata, from one hospital to one hospital. But then too, I'm telling you, hand surgeons or plastic surgeons of India, it's a sad affair that we means Sushrut gave the father of plastic surgery, and we have gone in the back seat. Now, these are the basic, why I've told you that anatomy is gateway to medicine, because you can see it, you can feel it. You have to just use your intelligence and sixth sense, you just clean, give the first aid. If you cannot, if you feel no, I don't have so many things, I just give a note that this tendon is injured, this tendon is injured, draw a rough sketch and you level whatever you have seen. Now, palmar aponeurosis. Now, parts central, medial and lateral. It's an expansion like this. Now, this is the lateral, this is the medial, this is central. The central part, palmar aponeurosis proper. The medial part covers the hypothenar muscles, lateral part covers the thenar muscles. Now, you can see this is the thenar, this is below hypothenar. Now, palmar aponeurosis proper, the triangle in shape, proximally blends with the flexor retiniculum, proximally flexor retiniculum. Medial and lateral palmar septa extend from the margins. Intermediate fibrous septum extends to palmar surface of third metacarpal. This part. And septa divide the palm into fascia line spaces. Now this is important. The septas, they form compartments. You will see in another lecture that if a section is taken like this, you can see space. This is important because if there is any injury or infection of the hand, which is very common. Now, pus and inflammatory exudates, they collect in these spaces. Or it is just a blunt trauma. You motorbike cut, go, and there's a blunt trauma, that might be hematoma, and that leads to some collection there. Now, of course, after antibiotic and first aid, there's no cut injury, but the collection has to be drained. That has to be done under anesthesia. Or even if you do a nerve block, median and ulnar nerve to be blocked with a 2% xylocaine. And that can be drained. Now, intrinsic muscles of the hand, the thenar group muscles, adductor pollicis, hypothenar group of muscles, and palmaris brevis, lumbricals, palmar and dorsal interossei. Now, thenar and hypothenar muscles over here, you can see these muscles here, lumbricals. This is the thenar muscles, this is the opponens digiti, flexor carpi digitorum. This is the tendon of palmaris longus. Now, lumbricals. You see these lumbricals attachment. These are the. Now, see, the tendon is getting inserted at these. Why it is important, and positioning of the hand. Like if any hand injury, when you give first aid, you bandage, then try to keep it in this hand, holding a glass. That gives a comfortable position, plus the muscles and all are in place in a relaxed state. You don't do like this. Of course, in certain things you have to put up a cock up if there is a nerve injury, and there are splints and all. That is a different issue and different subject also. Now, palmar interossei. Now, these are the palmar interossei muscles. Is bipinnate and unipinnate muscles are here. Unipinnate. You see, when you open, when in the dissections, you will be seeing them. Individually, you can see it. If you have a very good, do a very nice dissection, you can see every tendon and everything is going into the, to give you this flexion, extension. And main thing is, it is crucial to, because the vascular supply for each finger now dorsal interossei. These are the dorsal interossei. Abduction, adduction, movement. Now mid-palmar space. Now the mid-palmar space is triangle in shape. You can see in front flexor tendons of little, ring and middle finger, third and fourth lumbrical muscles, behind third and fourth interossei and metacarpal bones, lateral intermediate fibrous septum, medially hypothenar muscles separated by medial palmar septum and proximally closed by the flexor retinaculum. Yeah. Distally extends as diverticular to the webs of the fingers. Yeah. Now, the thenar space is a triangular in shape, in front flexor tendons of index finger, first and second lumbricals. Actually, these two fingers, the muscles and the lumbricals are first and second lumbricals. Behind adductor pollicis muscle, transverse head, first and second interossei and metacarpal bones, laterally thenar muscles supported by lateral palmar septum and medially intermediate palmar septum and proximally limited by flexor retinaculum, distally extends as the diverticular to the webs of the fingers. Now pulp spaces, the spaces between the palmar skin and distal phalanges of the all digits, skin connected to periosteum by fibrous septa, space subdivided into tight compartments. Infection of pulp space is known as Whitlow, pus drained by lateral incision. Now it is a very painful condition. You give antibiotic, analgesic, everything, but yet it is very, very painful. And because you can see you can feel and see that it is a tight, the aponeurosis and the fascia, the septa, it is a tight compartments. Naturally, if anything collects there, pus collects, then it it cannot go out like any abscess in any or the forearm or arm or your back or your abdomen, anterior surface, thigh, any place. It is not, it's painful definitely, it is not as painful or excruciating pain as the pulse faces because of the basic anatomy, because it cannot expand. And drainage is by the lateral incision of every space. You give a lateral incision, not sometimes it is swollen up like this, you make an incision in the middle, because because you see the compartment space, it's laterally. If you make an incision, open up a small, you give a hemostatic forceps and it just drain like this. But do it under local anesthesia, nerve block. Now the space of Parona, there might be a short note on it. Space of Parona situated in the forearm adjacent to the wrist. Spaces between the pronator quadratus deep and the flexor tendon superficial. Proximally related to the radial and ulnar bursa. In front, flexor digitorum profundus and flexor pollicis longus. Behind is a pronator quadratus. On each side, outer inner border of the forearm. The anatomical snub box. This is also a short note. It comes usually. Even if you are answering very well, it can be questioned in the viva also. When you are dissected parts are being demonstrated. Or there will be a tag, whatever it is there, labeled, and you will be, what is this? So, anatomical snub box. You answer. Then the examiner questions you. Please say the anatomy and the boundaries. Now, you see it in your own hand when you go out and stay in the dissection hall, and you see the anatomical snub box. Now, triangular depression on the radial side of the wrist becomes visible when the thumb is fully extended. In this, like this. Over there you will see like this. Over here you have see your own hand. Now, laterally, abductor pollicis longus and extensor pollicis brevis. Medially, extensor pollicis longus. Roof, skin and fascia crossed by the cephalic vein and superficial branch of radial nerve. Roof, skin and fascia crossed by the cephalic vein and superficial branch of the radial nerve. Floor, styloid process of the radius, scaphoid and trapezium, and base of the metacarpal bone. Now the first title side ka path jo I have showed you 5 slides. So you can see the importance of those diagrammatic pictures and to have the mnemonics that I have shown you. Now, floor is the styloid process of the radius, scaphoid and trapezium, base of first metacarpal, and content is the radial artery. Now, the radial artery is the content of the anatomical snub box. Here is a very good illustration here. Here. Now, this is the extensor pollicis longus tendon. This is the thumb This is the extensor pollicis brevis. This is the radial artery. This is the radial nerve, superficial branch. This is the extensor retinaculum. Now the flexor retinaculum is here, and this is the extensor retinaculum. Now this is the anatomical snuff box. Now these are just I'm showing you few slides. The hand is the most important tool. If you touch someone, the Mesenus corpuscles, they give the signal and you can feel it. Even in dark, see, you can, or the blind person, he just feels with his hand, and you can know. Even a friend blindfolds you, you just see like this, and hey Gautam, or you feel and recognize whose hand it is. It is the most sensitive and the contact. Now this picture is important. You just, important means I'm just giving you, I came across. Now this is the best. Now this is see, a man, old man is standing. This is the dress he's wearing. This is his face. This is the arm like this. That is showing the nose. Now this is the hand depicting a dog sleeping idle. Okay, and this is the lady just carrying a baby, and you can see. Oh. Now you can see the dress she wore is also giving a collar and frills of that old man's dress. Now, this is a famous painter, Leonardo da Vinci, plus scientist, anatomist, architectural drawings. He is famous. You just go into Google, search Leonardo da Vinci, and see his self-portrait he is drawing. Now, here is a man on a mule or gadha or khachar, whatever you say, and see his here, his eyes, his arm and forearm, and here's the thing. This is the way he's drawn is like it's mustache and your beards and all this. Now you can see he's drawing it with his left hand over here. Now this is just saying that how sensitive a human hand is, and how people using it. Now again, say hater khala. When a jadoo, anything you do, or you cook, you show some actions, you put some sign, it is the greatest fascinating tool. And also the touch, you can identify your anything. If you left your keys, load shedding, you will go and you will take. Now, this is Andre Vesalius, the greatest anatomist of modern era. He is demonstrating the dead body dissection, but you can see the picturization. See, he is thinking. When this man is thinking, he is dissecting and lecturing to his student. This student is taking a note, and all a keen observer, he is also put his hand in this place to how concentrated they are, and Eta hater khela. Now this is another journal, Anatomical Society of India, our official journal. Now you can see there are many, this whole thing are human, yellow, now you can see all the hands over here. Hands. Here, this man is holding like this. Now, again, the great, you are seeing every day in the college, and you can see Sushrita performing a plastic surgery of the year, and you can see this sister holding a bowl, and all these assistants are holding the patient because in those days definitely they had anesthesia, means alcohol or opium or something. Okay, naturally but that didn't give complete anesthesia. So, but in this condition, Sushrut is to perform many great surgeries, and more than 100 surgeons from every branch, modern surgeons, they attended they met in AIIMS Delhi to do some work on the tools used by research work or project, that how Sushrita used to work in those days. Now this is when I was a kid, these paintings were done by Robert Thom. Now in those days, Park Davis company, they used to give this postcard. So I happened to collect one postcard from my father and saw it, and that fascinated me. You just see this is the compassion, the hands of the doctor and the physician. Everything is in the thing that here, this, he's putting his hand on the shoulder of the child to give some comfort. He's palpating the liver, and also see this boy's mother is just holding the child's hand, and see her face, that this is the Hippocrates face and this is the boy's mother's face, how they are interacting. And the picture tells you so many things. Now, this is the shadow puppetry. You'll be seeing in your Facebook. You can see it in you could download in Google. But the imagery is all done by, agar aapka lumbricals torn ho gaya, your interossei got injured, then these tricks cannot be done. And then all over India, the miniature paintings, then embroidery work that is done by the hand.
Osmotic fragility test is not your performance topic. You don't need to perform it during your practical examination, but you need to know how osmotic fragility test is done and what is its significance, what are the conditions, what are the diseases where osmotic fragility is increased, and what are the diseases where osmotic fragility is decreased. Right? Okay, so this is a very simple practical. So for doing osmotic fragility test, you need to know a little bit of theoretical knowledge on osmolarity, right? So I guess by all of you know the normal osmolarity of blood right? Which is what Joel? 290 plus minus 5, 285 to 295 milliosmoles. What is the unit? Milliosmoles per okay, milliosmoles per liter. Now, what is the osmolarity of normal saline? Same. It is isotonic. So it will be almost we are calling 0.9%. Normal saline means how much concentration of sodium? 0.9%. 0.9%, right? So 0.9% NS is isotonic. That means if I infuse 0.9% saline or normal saline to a patient, the RBCs will remain intact. So this is our goal. While infusing fluid to the patient, RBCs should not be lysed, right? And the definition of fragility is it is the ease with which RBC membranes are lysed. Okay, so RBCs are we call it more fragile when they are exposed to hypotonic saline. Okay, when they are exposed to hypotonic saline, what will happen if we expose RBCs into hypotonic saline? RBCs will be swelled up. Okay, RBCs will be swelled up and ultimately they will lyse. Okay, and all the contents of RBCs will come out into the blood. Right. This is what happens when RBCs are exposed to hypotonic solution. Okay. Now we have saline solution, and by adding distilled water, we have prepared different concentration starting from 1 or 0.9%, starting from 1%. Starting from 1%, so we have 1% saline solution already we are having, and by adding drop by drop distilled water, we have prepared 12 test tubes from 1 to the final solution. Final concentration is 0. Final concentration is 0. So 0 will be only distilled water. Okay. Now on your practical book, I had a presentation, but I am not showing you because it is not having any extra information. Everything is given in your book, in your practical book. So in your practical book, it is written how to prepare those solution, the 12 test tubes, right? So starting from 1, then 0.88, then gradually we will reduce 0.45, 0.34, and ultimately 0. Okay. Different concentrations of saline. Okay. Okay. Now we will put drop of blood into each of the 12 test tubes. Okay. So you know, once it is exposed in 1%, RBCs will remain intact, right? Now gradually RBCs will initially resist lysis. So one point will come when RBCs will start lysis. Okay, RBCs will start lysis. So it is around 0.45% concentration, and the lysis will be complete at around 0.34%. Okay, so this is normal range of fragility. Normal range of fragility is 0.34 to 0.45. This is, or in some books it is written as 0.48. So this is the normal range. Okay, and you know, fragility is defined as it is the ease with which RBC membranes are lysed. Okay, so what are the conditions when RBCs we have increased fragility? That means very easily they are lysed even before reaching 0.48%. Say for example 0.7%, they are being lysed. Okay, examples are when the RBC shape is changed, and few examples are not always with the change in shape. So it is when RBC membrane are more fragile, very easily they are lysed. Examples are hereditary spherocytosis, hereditary erythrocytosis, right? So these are the examples where RBCs are more fragile. So that is osmotic fragility is increased. Okay, osmotic fragility is increased, and when osmotic fragility is decreased, that means RBCs will resist. So that means even at 0.4% saline solution, they will not be lysed. Okay, and the examples are iron deficiency anemia, thalassemia. Okay, for your level, you remember two examples. Osmotic fragility is increased, hereditary spherocytosis, hereditary erythrocytosis, and osmotic fragility is decreased, thalassemia and iron deficiency anemia. Okay, so here we have 12 test tubes, right? And we have already prepared, before your arrival here, we have already prepared 12 test tubes. Okay, so starting from tube 1, tube 12. Okay, tube 1 is having 1% of saline solution. Tube 2, 0.88. Okay, and gradually we are reducing it. You just see in your book how to prepare this saline solution. And finally, this 12th tube is having 0%. That means only distilled water. Okay, so it is the mixture of distilled water and 1% saline. And this tube is having the highest concentration of saline. Okay, and this tube has got the lowest concentration of saline, only distilled water. Okay, so 1%, and normal isotonicity is 0.9% saline solution. So almost in this tube RBCs will be intact. So you will see the drop of blood inside this tube, and the remaining fluid will be clear. Okay, and gradually, say for example, this tube is having concentration of 0.45%. Okay, so this will be the tube where RBCs will start to lyse. Okay, so you will see the drop of blood inside, and the remaining fluid will be slightly reddish. Okay, and this red color will increase. Gradually, it will become dark as the RBCs, more RBCs are getting lysed. Right? Okay. Okay, now we will do the experiment. Anyone please supply blood for us.
But why there is a formation of lipid and protein? Why there is association of lipid and proteins? It is because of the lipid, not because of proteins. Because lipids are insoluble in some, and because of its insoluble nature, it cannot be transported from here to here. And for lipid transportation, lipids should be made soluble, and lipids are purely hydrophobic molecules, or some lipids are amphipathic. To make the soluble, lipids should be combined with a hydrophilic substances, and proteins are the hydrophilics. So it is necessary for the transport of the lipid to combine with proteins. Purpose of the transport of lipids. Now, what are the lipids in our body, in our plasma? Plasma lipids are of two types. Plasma lipids of the two types. One is purely non-polar, and another one is the both polar and non-polar properties are present, and that is called amphipathic. When polar and non-polar both properties are present in a substance, that substance are called amphipathic. উভচর অ্যামফিবিয়া মানে উভচর জলে এবং ডাঙায় নদী চড়ে অ্যামফিবিয়া সেখান থেকে এসেছে অ্যামফিপ্যাথিক it has both characters polar and non-polar. Now what are the amphipathic lipids and what are the non-polar lipids? Amphipathic lipids are কোনটা? Phospholipids. Phospholipids and cholesterol. Cholesterol is amphipathic because of the hydroxyl group present in the one hydroxyl group at the 3 carbon. So cholesterol is polar to some extent, and it is non-polar because the ring is non-polar. What is called the ring? Cyclopentano or hydroxyphenol ring. This ring is non-polar, but hydroxyl group is polar, so it is amphipathic. And the purely non-polar lipids. Which one is the purely non-polar lipids? Number one is the triglyceride. Triglyceride or triacylglycerol, whatever you call. And another one is the when cholesterol becomes esterified, it will be totally non-polar because hydroxyl group will be utilized for ester bond, ester with fatty acid. Then cholesterol, remember, cholesterol is derived lipid. Cholesterol is amphipathic lipid, but cholesterol ester is simple lipid, and it is purely non-polar lipid. This is the difference between the cholesterol and cholesterol esters. Cholesterol and cholesterol esters are the difference is high. Cholesterol ester is purely non-polar, but cholesterol itself is amphipathic. And these are the four lipids are present in the plasma, which are required to be transported, and for transportation it requires some proteins, and the proteins parts are called apoproteins. Proteins parts are called apoproteins. Now what are the apoproteins? Present in the lipoproteins. Name the apoproteins present in the lipoproteins. What will be the answer? Your answer will be A2, B2, C2, D. And A is again divided into A, A1, A2, A4. There is no A3. B, there are two B. One is 48, another is 100. Okay? There are 3C. C1, C2, C3. There is only one B. And lastly, there is B. In order of A, B, C, D, E, we have arranged lipoproteins. Now I will tell which apoproteins are present in which lipoproteins. These are the apoproteins which are present in the lipoproteins. And before starting the various classes of the lipoproteins, let us draw the structure of the lipoprotein, or structural assembly of the lipoproteins. Structural assembly of the lipoproteins. Structural assembly. That means disposition, where lipids are present and where proteins are present in a micelle-like structure. In a micelle-like structure, where the position of the lipid and where the position of the proteins. This is a spherical structure. Spherical structure, and one layer of the phospholipid, one layer of the phospholipid diagrammatic structure. Jana? Diagrammatically, we represent phospholipid like this. This is head and this is tail. This is head, this is tail. This is head, this is tail. In this way, phospholipids are present, and in between phospholipids are amphipathic, so it will be present outside. Cholesterol ester and triglyceride is a purely non-polar. It will be in the core. Cholesterol will be present in the cholesterol. দুটো ধরনের লিপিড আছে, একটা বাইরে থাকবে, একটা ভেতরে থাকবে। বাইরে কারা থাকবে? বাইরে কোলেস্টেরল থাকবে আর ফসফোলিপিড থাকবে। বাইরে কোলেস্টেরল থাকবে, কোলেস্টেরলটা আমি এভাবে লিখছি। বাইরে কোলেস্টেরল গুলো বাইরে থাকবে, তাহলে এগুলো হচ্ছে ফসফোলিপিড, এগুলো হচ্ছে গিয়ে কোলেস্টেরল। আর ভেতরে কি থাকবে? ভেতরে হচ্ছে এটা হচ্ছে কোলেস্টেরল এস্টার, আর এটা হচ্ছে গিয়ে টিজি, কোলেস্টেরল এস্টার টিজি। Now this is the structural assembly of the lipids. These are the amphibitic lipids, these are the non-polar lipids. Outside is the amphibitic, and in the inside or the core of the lipoprotein there is totally non-polar lipids. And lipoproteins will be present in the periphery. Because lipoproteins are soluble, proteins are soluble. These are the lipoproteins. So this is the structural assembly of a lipoprotein. Structural assembly of the lipoprotein. Here you have to draw this when lipoproteins in short note or in you have to describe the lipoproteins. You have to draw the general structure of the lipoprotein. Then this is the general structure of the lipoprotein. Now what are the classification of the lipoproteins? Or what are the types of the lipoproteins? Generally there are 4 major types. Generally there are 4 major types. First one is the chylomicron. We will arrange 1, 2, 3, 4 as per density. Next is the very low density lipoprotein. Very low density lipoprotein. Next is the LDL, low density. Low density lipoprotein. Next is the HDL. HDL is the high density. High density lipoprotein. Now, what is the density? Density তাহলে কত হবে? কার density হবে, এটা হবে less than 0.95, এটা হবে 0.95 to 1.006, এটা কিন্তু গ্রাম পার মিনিট। এটা থেকে এটা বাড়লো, এবার এটা আবার এর থেকে বাড়বে 1.019 to 1.063, এটা তার থেকে বেশি 1.063 to 1.210। সেজন্য এটা হাই ডেনসিটি। সবচেয়ে কম ডেনসিটি হচ্ছে কাইনেমাইক্রন, তারপরে হচ্ছে ভিএলডিএল, তারপরে এলডিএল, তারপরে এসডিএল, ইন অর্ডার অফ ascending density. Now portion of the what are the portion of the lipid and what are the portion of the protein? Lipid, protein, percentage. It is a 99%, 1%. Chylomixon. This is the 90-10. This is the 80-20. And this one is the 50-50. এটা মনে রাখবে কারণ বাইরে বইয়ে দেখবে রেঞ্জ আছে রেঞ্জ মনে রাখতে পারবে না এটা এভারেজ ফিগার দেবে যেটা তোমার মনে রাখতে সুবিধা হয় সেটা আমি বলেছি আমি এইটা তোমার মনে রাখতে পারবে 99-1, 90-10, 80-20, 50-50. This is the proportion of the lipid and protein. দেখবে লিপিড যেখানে কম বেশি এবং প্রোটিন যেখানে কম তার ডেনসিটি সবচেয়ে কম আর যেখানে লিপিড বেশি লিপিড কম প্রোটিন বেশি তার ডেনসিটি সবচেয়ে বেশি হবে কারণ লিপিড তো হালকা ফ্যাট অয়েলস এগুলো তো হালকা কিন্তু অ্যালবুমিন গ্লোবুলিন প্রোটিন এরা ভারী হ্যাঁ মলিকুলার ওয়েট বেশি ডেনসিটি ওদের বেশি সেই জন্য they are heavier. Proteins are heavier than lipid. Then major lipid, then you have called it lipid. But in a lipoprotein, there are 4 classes of the lipid. And it is the 4 class. Among the 4 classes, there is a major lipid. That means all lipids are present in all lipoproteins. Remember, all lipids are present in all lipoproteins. But there is still a major lipid. That is predominant lipid in case of VLDL and chylomicron, Tg. In case of VLDL and chylomicron, it is Tg. In case of LDL, it is cholesterol. Cholesterol and cholesterol ester. And in case of HDL, major lipid is the phospholipid. Phospholipid as well as cholesterol. Okay? This is the lipoprotein, this is the density, this is the lipid protein ratio, and this is one of the major lipid. Then, which apoproteins are present in which lipoproteins? Next come, which apoproteins are present in which lipoproteins? আমি এদিকটা মুছে দিচ্ছি এখানে লিখছি apoproteins. We have already named the apoproteins A, B, C, D. We have named the apoproteins now. There will be more than one apoproteins in one. In case of chylomicron, it is the A apoprotein আছে, B48 আছে, C আছে, E আছে. In case of VLDL, it is B100 আছে, C আছে, E আছে. C মানে C2, C3, C4, সব C. C1, C2, C3. In Roman, not in Alphabet. Always C1, C2, C3 is in Roman. A1, A2, A4 in Roman. B100 and LDL. LDL is the single lipoprotein. Only lipoprotein which have single lipoprotein, that is LDL, and that is B100. Single lipoprotein present in only one lipoprotein, that is LDL, and the name of the lipoprotein is the B100. And the HDL, A, D, C, E. That now major lipid concern I am going to say, then major Apoprotein আছে, major apoprotein is the there. B48. In case of chylomicron, major is the B48. In case of VLDL, major is the B100. In case of LDL only, major. In case of HDL, major is the A. In circle potential BC, that is major. Now, before going to metabolism of lipoproteins, we will first discuss about the lipid profile. What is lipid profile? This is frequently asked. Lipid profile present in the blood, and we estimate the lipid profile. Physicians prescribe lipid profile to diagnose many disorders, particularly coronary artery disease. Particularly coronary artery disease, physicians prescribe lipid profile. Then what are the parameters of the lipid profile? What are the components of the lipid profile that we have to test? Components of the lipid profile is the total cholesterol. Total cholesterol কেন বলছি ভাই? টোটাল আমি পরে বলছি। Not only single, শুধু cholesterol বললাম না কেন? Triglyceride. तीन नंबर VLDL cholesterol, not VLDL. Now what is the VLDL and VLDL cholesterol I am discussing? LDL cholesterol, number 5. HDL cholesterol. C means cholesterol. VLDL cholesterol, LDL cholesterol, HDL cholesterol. Now, what is the difference of the VLDL and VLDL cholesterol? VLDL cholesterol is the only the cholesterol component of the VLDL. একটা লাইপোপ্রোটিনে তো সবই থাকে। VLDL বা বলো বা LDL বলো বা HDL বলো, জেনারেল স্ট্রাকচার চিন্তা করো, সেখানে সব কিছুই আছে, তার মধ্যে কোলেস্টেরলও আছে। এবার শুধু যদি কোলেস্টেরলটাকে যদি আমি কাউন্ট করি, তখন সেটা হবে VLDL কোলেস্টেরল। আর যদি টোটাল স্ট্রাকচারটা যদি কাউন্ট করি, সেটা হবে VLDL। তাহলে কোনটা বেশি হবে? VLDLটা বেশি হবে। VLDL কোলেস্টেরলটা কোলেস্টেরল পোরশন অফ দ্য VLDL। এই কোলেস্টেরল পোরশন অফ দ্য VLDL, তাহলে কোলেস্টেরল কোন জায়গায় আছে? VLDL এর উপর আছে, LDL এ আছে আর HDL এ আছে। অ্যাকচুয়ালি এই তিনটে লাইপোপ্রোটিনই কিন্তু মূলত কোলেস্টেরল থাকে। এই জন্য এই তিন থেকে যদি আমি যোগ করি, তাহলে যেটা দাঁড়াবে সেটাই হচ্ছে কি টোটাল কোলেস্টেরল। যেটা আমি আগে বলেছি। হ্যাঁ, তাহলে আমাদের ডিফারেন্ট টোটাল কোলেস্টেরল কথাটা এটা লিখলাম এই জন্যই, ইট ইজ আ সামেশন অফ VLDL কোলেস্টেরল, LDL cholesterol and HDL cholesterol. It is a summation of 3 cholesterol, that is cholesterol present in the VLDL plus cholesterol present in the LDL plus cholesterol present in the LDL. তারপরে সবচেয়ে বেশি কোলেস্টেরল কোথায় থাকে? সবচেয়ে বেশি কোলেস্টেরল থাকে LDL এ। এই জন্য LDL কোলেস্টেরলটাকে আমরা ব্যাড কোলেস্টেরল বলি। और LDL के बोलिए हमरा बैड lipoprotein. LDL is a bad lipoprotein and LDL cholesterol is bad cholesterol. HDL is a good lipoprotein. HDL cholesterol is a good cholesterol. Why it is good and why it is bad, I am coming. But this is the parameters to be estimated as lipid profile. This is the lipid profile that is present in our blood, and it is for the lipid profile. What is the precaution to be taken before the drawing of the blood? For the drawing of the blood, at least 12 hours fast is necessary. At least 12 hours fast is necessary. তার কারণ যদি আমি 12 hours ফাস্ট না করি যে প্রোফাইলটা আমি পাবো, that will be incorrect. There will be major portion will be triglyceride. Major portion will be triglyceride because after absorption, after meal, triglyceride content will be high. But at the base level, we are required to measure the base level. So for the measurement of the base level, we have to wait for 12 hours, at least 12 hours after meal. We have to wait at least for 12 hours. Then if সকাল যদি সে আমি ব্লাড টানি, সে যদি রাত 10টায় খায়, তাহলে আমি পরের দিন কখন ব্লাড টানবো? পরের দিন 10টার পরে, not before 10, not before 10, 12 ঘন্টা আছে, এবার 12 ঘন্টা কি 13 ঘন্টা হয়, 14 ঘন্টা হয়, 16 ঘন্টা হয়, that is acceptable. কিন্তু 12 ঘন্টা যদি 8 ঘন্টা হয়, সকাল মানে 11টার সময় ভাত খেয়ে যদি 6টার সময় ব্লাড দেয়, হবে না। এটা ইনকারেক্ট রেজাল্ট আছে, এটা জানতে হবে। This is the practical point. Now LDL cholesterol. What is the difference between the LDL cholesterol and HDL cholesterol? It is bad. It is good. Can bad? Concentration is directly proportional to incidence of atherosclerosis. So, what is atherosclerosis? That is deposition of the cholesterol plaque in the blood vessel. Atherosclerosis and coronary artery disease. যত কনসেন্ট্রেশন হবে তত ইনসিডেন্স অফ atherosclerosis এবং coronary artery disease এর ইনসিডেন্স বাড়বে। আর এটা concentration is inversely proportional. ওটা যেমন ডাইরেক্টলি প্রপোর্শনাল, এটা যত কনসেন্ট্রেশন হবে তত ভালো। ইনভার্সলি প্রপোর্শনাল টু ইনসিডেন্স অফ coronary artery, ইনসিডেন্স অফ atherosclerosis and coronary artery disease. সেই জন্য একটাকে বলছি গুড, একটাকে বলছি ব্যাড। এটাকে এটা ফরওয়ার্ড কোলেস্টেরল ট্রান্সপোর্ট করে, it causes reverse cholesterol transport. What is forward and reverse? Reverse cholesterol transport. LDL causes carrying of the cholesterol from the liver to the tissues and blood vessels. লিভার থেকে কোলেস্টেরল গুলো টেনে 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 প্লাজমাতে নিয়ে আসে, প্লাজমা থেকে টিস্যুতে এবং ব্লাড ভেসেলে নিয়ে যায়। দিস ইজ ফরওয়ার্ড কোলেস্টেরল ট্রান্সপোর্ট। দিস ইজ ডান বাই LDL, so it is bad. And what is the function of the HDL? It reverse cholesterol transport. এবার তুমি রিভার্স করো, that means it draws the cholesterol from the tissue and pour it to the liver. এবার লিভারে গিয়ে ঢালছে। It draws the cholesterol from the tissues and blood vessels and pour it to the liver, where the fate of the cholesterol is the bile acid. In this way, HDL acts as a good cholesterol. Why it is good and why it is bad? This is very frequently asked. and you have to categorically answer. Now let us talk about the metabolism. Metabolism of the first metabolism of the chylomicron. I will start the metabolism of chylomicron. প্রত্যেক উৎপত্তি হয় ওর কিভাবে তৈরি হয় আর কিভাবে ওর ধ্বংস হয়, এই হচ্ছে মেটাবলিজম। তৈরি হয় এটা ইন্টেস্টাইনে, কারণ সোর্স হচ্ছে কি ডায়েটারি লিপিড। আমরা যে লিপিড খাই সেই লিপিডটা ইন্টেস্টাইনে যায় এবং ইন্টেস্টিনাল সেলের মধ্যে ঢোকে কাইলোমাইক্রনটা তৈরি হয়। কাইলোমাইক্রনের যে কম্পোজিশন অনুসারে এবং একক প্রোটিন অনুসারে কাইলোমাইক্রনটা তৈরি হয়। কোথায় তৈরি হয়? ইন্টেস্টাইনে। কিন্তু ভিএলডিএল তৈরি হবে কোথায়? লিভারে। বোথ কন্টেইন দুটোই ট্রাইগ্লিসারাইড রিচ লাইপোপ্রোটিন, একটাতে 99% আছে, একটা প্রায় 90% আছে। কিন্তু একটা তৈরি হয় কাইলোমাইক্রন তৈরি হয় ইন্টেস্টাইনে, এটা হয় লিভার। কাইলোমাইক্রন যেহেতু ইন্টেস্টাইনে তৈরি হয় এবং এটা ডায়েটের উপর নির্ভর করছে, সেজন্য এটাকে বলা হয় এক্সোজেনাস লিপিড। এক্সোজেনাস লিপিড আর এক্সোজেনাস ট্রাইগ্লিসারাইড। আর যে সমস্ত ট্রাইগ্লিসারাইড বা লিপিড লিভারে তৈরি হয় সেগুলো দিয়ে যে লাইপোপ্রোটিন তৈরি হয় তার নাম হচ্ছে ভিএলডিএল। সেজন্য ভিএলডিএল এর যে লিপিড থাকছে দ্যাট ইজ কল্ড এন্ডোজেনাস লিপিড। এক্সোজেনাস আর এন্ডোজেনাসের মধ্যে তফাৎ আছে। এক্সোজেনাস মানে আমি বাইরে থেকে সরবরাহ করছি, সাপ্লাই করছি বাই ডায়েট। এন্ডোজেনাস কিন্তু ডায়েটের উপর ডিপেন্ড করছে না, এন্ডোজেনাস বডি তৈরি করছে। এন্ডোজেনাস means it is synthesized within the body and exogenous means it is supplied by diet. So chylomicron is the exogenous lipid or exogenous lipoprotein and the source is the intestine. Intestine from dietary lipid. It is secreted from the intestine and via lymphatics. Via lymphatics, it is present in the blood. And how when present in the blood, it will be like, what are the main apoprotein? 48. B48. What is the difference between the B48 and B100? It is a single, it is a same polypeptide chain. When the total polypeptide chain is present, it is B100. When the 48% of the chain is present, it is B48. B48 is synthesized in the liver. B100 is synthesized in the liver. Total chain is synthesized in the liver, and partial chain, that is B48, it is synthesized in the intestine. There is the difference between the 48 and 100. It is a single same polypeptide chain. When all the amino acids are present, 100%, it is 100. When the 48% present, it is B48. So এখানে যেটা আছে that is B48. এছাড়াও কি থাকবে? এছাড়াও থাকবে এ আছে, এ থাকবে, আর থাকবে সি, আর থাকবে ই। সি আর ই কিন্তু প্রথমে থাকবে না, যদি আমি নেসেন্ট বলি থাকবে না, ম্যাচিউর হলে থাকবে, পরে আসছে। এটা হচ্ছে নেসেন্ট। নেসেন্ট নেসেন্ট মানে জানো তো, জায়মান। সদ্য তৈরি হচ্ছে, সদ্য যদি তৈরি হয় তাহলে সিআরই থাকবে না, কিন্তু পরে সিআরই আসবে। সিআরই কিভাবে আসবে? সিআরই আসবে এইচডিএল থেকে। ইট ইজ ফ্রম এইচডিএল। এইচডিএল কে বলা হয় স্টোর হাউস অফ দা সিআর অ্যাপোসিয়ান অ্যাপোইন। এইচডিএল কে বলা হয় স্টোর হাউস অফ অ্যাপোসিয়ান অ্যাপোইন। এই স্টোর হাউস থেকে সিআরইও নিয়ে আসে। এ থাকবে, সি থাকবে, ই থাকবে, এই সিআরই এখান থেকে আসবে, এখান থেকে ই যাবে, and it becomes male lipid হচ্ছে TG, it is nascent, it is mature, mature chylomicron, it is a nascent chylomicron, it becomes after acquiring C and E, it becomes mature. After acquiring C and E from the HDL, it becomes mature. And after mature, what will happen? After mature, it will decay. Everything যা হয় ছোট থেকে বড় হয়, বড় থেকে বড় থেকে মরে। আলটিমেট ফেট হচ্ছে গিয়ে it will be destroyed. এই destroy করতে গেলে কি একটা এনজাইম দরকার। সেই এনজাইমটার নাম হচ্ছে গিয়ে লাইপোপ্রোটিন লাইপেজ, যেটা ট্রাইগ্লিসারাইডকে ভাঙবে। মেন লিপিড হচ্ছে গিয়ে ট্রাইগ্লিসারাইড। সো ট্রাইগ্লিসারাইডকে যদি আমি ভাঙতে পারি তাহলে ওটা সাইজে ছোট হয়ে যাবে, সাইজে ছোট হয়ে যাবে। এই ট্রাইগ্লিসারাইডকে ভাঙার জন্য কি দরকার? এলপিএল, লাইপোপ্রোটিন লাইপেজ। এটা কোথায় থাকে? টিস্যুতে থাকে। কোন টিস্যুতে? এক্সট্রা হেপাটিক টিস্যু। Extra hepatic tissue containing lipoprotein lipase causes hydrolysis of the triglyceride to fatty acid and glycerol. যে কোনো lipase, it may be lipoprotein lipase, it may be lingual lipase, it may be pancreatic lipase. There are many lipase in our body. Lipase is present in the liver, that is called hepatic lipase. Pancreatic lipase, লিকুয়াল লাইপেজ জিভে নিচে আছে। আর কি বললাম? লাইপোপ্রোটিন লাইপেজ আর একটা হেপাটিক লাইপেজ। এতগুলো লাইপেজ আছে কিন্তু বডি। প্রত্যেকটা লাইপেজের ফাংশনটা একটু একটু আলাদা, কিন্তু রিঅ্যাকশনটা একই। রিঅ্যাকশনটা কি? ট্রাইগ্লিসারাইড টু ফ্যাটি অ্যাসিড এন্ড গ্লিসারল। তাহলে দিস ইজ এক্সট্রা হেপাটিক টিস্যু। Triglyceride will be vanished to some extent by fatty acid and glycerol. And it will donate again C and E. C will go to the HDL along with A and A will go to the HDL. মানে C and A কে ও পাঠিয়ে দেবে, দেবে না, তারপরে ধ্বংস হবে। ধ্বংস হলে পরে আলটিমেটলি কি দাঁড়াবে? আলটিমেটলি যেটা দাঁড়াবে সেটা হচ্ছে গিয়ে কাইলোমাইক্রন রেমন্যান্ট, যেটাকে বলছি রেমন্যান্ট অফ দ্য কাইলোমাইক্রন। Short in size, it is large in size, it is become short in size because of the reduced triglyceride which is broken down to free fatty acid and glycerol. It becomes small in size because of lesser content of the TG, and it contains B48 as well as it also contains E. এগুলো কিন্তু ছিল, এগুলো কিন্তু পাঠাইনি। B48 আছে, C আছে, E আছে, K আছে। A আর C কে কিন্তু HDL পাঠিয়ে দিয়েছে। A আর C কে HDL পাঠিয়ে দিয়েছে। তাহলে থাকলো কি? B48 আর E. This is taken up by the liver. This is taken up by the liver via receptor. এখানে receptor থাকে সেই রিসেপ্টর দিয়ে এটা লিভারে চলে যায়। এখন অ্যাপোপ্রোটিন যেগুলো বলছি, অ্যাপোপ্রোটিনের একটা ফাংশন আছে। কি ফাংশন? অ্যাপোপ্রোটিনের ফাংশন হচ্ছে তিনটে। আমি এটা বলিনি, অ্যাপোপ্রোটিনের ফাংশন হচ্ছে তিনটে। একটা ফাংশন হচ্ছে ক্যারিয়ার ফাংশন আর ট্রান্সপোর্ট ফাংশন। হ্যাঁ, আগে আমি বলেছি। নাম্বার 2 ফাংশন ইজ দ্য ইট অ্যাক্টস অ্যাজ এ কোএনজাইম। ইট অ্যাক্টস অ্যাজ এ কোএনজাইম। যেমন in case of lipoprotein lipase, it is activated by the C2. C2 is the coenzyme of the lipoprotein lipase. C2 activates lipoprotein lipase. Our C3 will inhibit lipoprotein lipase. In this way, it acts as a cofactor or coenzyme. This is the second function. Third function, it acts as a ligand for the receptor. যেমন এখানে রিসেপ্টরটা যে আছে, এই রিসেপ্টরে কিন্তু যে কোনো জিনিস বাইন্ড করবে না। এই রিসেপ্টরে বাইন্ড করবে ই রিসেপ্টর। দ্যাট মিন্স যদি ই অ্যাপোপ্রোটিন কোথাও থাকে, that will be taken up by this receptor. So it acts as a ligand. It acts as a ligand. তার কি ফাংশন হলো? ক্যারিয়ার ফাংশন, কোফ্যাক্টর or coenzyme function. Third function is the ligand function. Three functions of the apoproteins. Now this is the origin and fate of the chylomicron. Origin is the intestine, fate is in the liver. এবার আমি 12 ঘন্টা ফাস্টিং কেন বলেছি? এখানে কিছু হবে যে 12 ঘন্টা যদি ফাস্টিং আমি যদি না করি, তাহলে ব্লাডে ওই যে ইন্টেস্টাইন থেকে কাইলোমাইক্রনটা চলে এলো, তখন হিউজ অ্যামাউন্ট অফ কাইলোমাইক্রন তোমার ইন্টেস্টাইনে চলে আসে। হিউজ অ্যামাউন্ট অফ কাইলোমাইক্রন will appear in the intestine after taking meal. After taking meals, এই কাইলোমাইক্রনকে আমাকে ক্লিয়ার করতে হবে। For the clearance of the chylomicron or for the clearance of the triglyceride, we have to wait for 12 hours after taking meal. Just after taking meals, there will be flooding of the chylomicron in the blood. So, lipid profile estimation will not be correct. Now we will see metabolism of the VLDL. Metabolism of the VLDL is the similar to LDL. Similar to VLDL, chylomicron. Both are triglyceride rich. Metabolism of VLDL is more or less similar to chylomicron. Only the difference is the origin. Here the VLDL is the, I have just mentioned, it is the endogenous lipid. The endogenous lipid কোথায় থাকবে? It will be present in the liver. তাহলে এটা সোর্স হবে লিভার। আগে যেমন সোর্স যেমন ইন্টেস্টাইন ছিল, এখানে সোর্স হবে লিভার। লিভার থেকে এটা সিক্রেশন হবে VLDL। কিরকম হবে VLDL? VLDL কি থাকবে? B100 থাকবে, C থাকবে, E থাকবে, কিন্তু এ থাকবে না। এ থাকবে কাইলোমাইক্রন। এখানে কোনো এ নেই, এখানে আছে C আর E আর B100। B48 নেই, এখানে আছে B100। ওখানে ছিল B48, এখানে আছে B100 এবং B100 এবং B48 এর ডিফারেন্স আমি বলেছি। B100 হচ্ছে কি সবচেয়ে লার্জেস্ট অ্যাপোপ্রোটিন এবং এর প্রচুর অনেক মানে মলিকুলার রেট প্রায় 5,50,000 মলিকুলার রেট হবে। বিরাট বড় একটা প্রোটিন B100, very large protein B100, and it is present in the VLDL as well as in the LDL. Now it is similar. I have to talk about it is same. There is also role of HDL here. HDL কি করবে? CRE কে পাঠিয়ে দেবে। CRE কে পাঠিয়ে এটাকে আরো বেশি কনসেন্ট্রেশন বাড়িয়ে দেবে। এইচডিএল থেকে সিআরই নেবে, এইচডিএল থেকে সিআরই নেওয়ার পরেই তবেই হবে ম্যাচিওর। প্রথমে যদি একটা গোল ছিল তখন তুমি দিছে, এই দুটো গোল যখন হলো, মানে যখন সিআরই যখন এখান থেকে এলো এইচডিএল থেকে, তখন ইট বিকামস ম্যাচিওর। Mature failure. Now the fate of the mature failure is the same as the chylomorphism, that is, it is acted upon by the lipoprotein lipase. Similarly, এটাও তো ট্রাইগ্লিসাইড আছে, মেন লিপিড হচ্ছে ট্রাইগ্লিসাইড। এখানে main lipid is a triglyceride, so it will be acted upon by the lipoprotein lipase, similar to chylomicron. Lipoprotein lipase is present in the extrahepatic tissue, similar to chylomicron. Extrahepatic tissue. Okay, then this becomes smaller by losing fatty acid and glycerol. That means it loses triglyceride. It loses triglyceride. It becomes small in size. Main lipid হচ্ছে কি এখানে TG as well as কিছুটা cholesterol, TG cholesterol, main lipid কিন্তু TG। এবার TGটা ছোট হয়ে গেল, TG চলে গেল, ফ্যাটি অ্যাসিড এবং গ্লিসারল কনভার্ট হয়ে সাইজটা ছোট হয়ে যাবে, কিন্তু এটা থেকে যাবে B100 থাকবে, আর থাকবে E থাকবে। B100 আর E থাকবে, কিন্তু সিটা চলে যাবে এইচডিএল এর কাছে। সি এবং সি, তারপরে সিটা শুধু এইচডিএল এর কাছে চলে যাবে। আমি এখানে লিখেছি, এ তো হবে না যদি যে রং না, ও এইচডিএল এ থাকবে, ঠিক আছে, এখানে এ থাকবে না, এইচডিএল এ আছে, ঠিক আছে, সিটা চলে আসবে, সিটাকে ফেরত দেবে, সিটা নিয়ে এসেছিল এইচডিএল কাছ থেকে, আবার যখন ধ্বংস যখন হবে তখন সিটাকে আবার ফেরত দিয়ে দেবে। কেন যে দেয় আর কেন যে ফেরত দেয় আমি জানি না, কিন্তু এটাই নিয়ে যাই হোক, এটাকে হচ্ছে VLDL remnant। VLDL remnant এর আরেকটা নাম আছে, VLDL remnant এর আরেকটা নাম হচ্ছে IDL, মানে ইন্টারমিডিয়েট ডেনসিটি লাইপোপ্রোটিন। I means intermediate, L means low, H means high, ওর মাঝখানে যদি ডেনসিটি হয়, হাই আর লোর মাঝখানে, that is intermediate density lipoprotein। এবং VLDL এর যে remnant, এই রেমন্যান্টের নাম হচ্ছে গিয়ে আইডিএল। ভিএলডিএল ছোট হয়ে গেলে যে জিনিসটা পড়ে থাকছে তার নাম হচ্ছে গিয়ে আইডিএল। এই আইডিএল এর দুটো ফ্যাক্ট, দেয়ার আর টু ফ্যাক্টস অফ দ্য আইডিএল। কি ওখানে যেমন কাইলোমাইক্রন রেমন্যান্টের একটাই ফ্যাক্ট ছিল, ইট গোজ টু দ্য লিভার। এখানে কিন্তু আইডিএল বা ভিএলডিএল রেমন্যান্ট এর ফ্যাক্ট হচ্ছে দুটো। নাম্বার ওয়ান ফ্যাক্ট ইজ ইট উইল বি কনভার্টেড টু এলডিএল, it will be converted to LDL. This is the number one fact. And number two fact, it will go to the liver. তাহলে এটা সরাসরি লিভারে চলে যেতে পারে, আবার বেশ কিছুটা পোরশন এলডিএল এ কনভার্ট হতে পারে। তার মানে আইডিএল এর দুটো ফ্যাট, একটা হচ্ছে লিভারে চলে যেতে পারে, আর একটা ফ্যাট হচ্ছে গিয়ে it may be converted to LDL. That means VL প্রথমে আমি VLDL হলো, তারপরে হলো আইডিএল, আইডিএল থেকে হবে এলডিএল। দিস ইজ দ্য ফ্লো, এলডিএল টু আইডিএল টু এলডিএল। হ্যাঁ, আইডিএল এর এই ক্ষেত্র হতে পারে, আর একটা ক্ষেত্র হচ্ছে গিয়ে taken up by liver, liver অ্যাকসেপ্ট করে নিতে পারে, লিভার অ্যাকসেপ্ট করবে ওই P100 রিসেপ্টর দিয়ে। এখানে একটা P100 রিসেপ্টর থাকবে, যেটাকে বলছি সেই রিসেপ্টর দিয়ে ওটা চলে যেতে পারে। আবার এলডিএল যেটা তৈরি হলো, এলডিএল এর সেট কি? আমি ভিএলডিএল এর সেট বললাম, আইডিএল, আইডিএল এর সেট হচ্ছে দুটো, একটা টেকন আপ বাই দ্য লিভার আর একটা ফরমেশন অফ দ্য এলডিএল ইন দ্য প্লাজমা। Now how will be the fate of the LDL? Fate of the LDL, that it is some portion it goes to the liver and some portion it goes to the various tissues for deposition of the cholesterol. LDL is taken up both by liver as well as by extra hepatic tissues. ওখানে যেমন আগে যেমন শুধু লিভার টেক আপ করতো, এক্ষেত্রে কিন্তু LDL will be taken up by the liver as well as by the extrahepatic tissue, blood vessels, macrophage, etc. সেই জন্য LDL যদি ওখানে জমে, LDL হচ্ছে মেজর পোরশন হচ্ছে কোলেস্টেরল, কোলেস্টেরল is the major lipid of the LDL, so deposition of the LDL means deposition of the cholesterol. কোথায় ডিপোজিট করছে? in the blood vessel, in the tissue, and when it is deposited in the coronary artery becomes occluded and the result is the myocardial infarction. This is the fate of the LDL. তাহলে VLDL থেকে IDL হবে, IDL থেকে LDL হতে পারে, IDL থেকে আবার লিভারে চলে যেতে পারে। LDL এর দুটো প্লেট, LDL can be taken up by the liver, LDL can go to the various tissues. তাহলে LDL এর কি ফেট হবে? LDL can be taken up by the liver আর ভেরিয়াস টিস্যুতে চলে যেতে পারে। এই যে যাচ্ছে, এই জায়গাটা একটু হার্মফুল। দিস ইজ দ্য হার্মফুল, দিস ইজ বেনিফিশিয়াল। যদি লিভারে চলে যায়, ঠিক আছে, লিভারে গিয়ে বাইল অ্যাসিডে কনভার্ট করবে, ইন্টেস্টাইনে চলে যাবে, ইন্টেস্টাইন থেকে বেরিয়ে যাবে থ্রু স্টুল। ওকে, দ্যাট ইজ বেনিফিশিয়াল, বাট when it goes to the various tissues, it is harmful. And HDL যেটা করে সেটা কিন্তু ঠিক উল্টো কাজটা করে, কখনো টিস্যুতে নিয়ে যাবে না কোলেস্টেরলকে, কখনো টিস্যুতে নিয়ে যাবে না, ও ঠিক উল্টো কাজটা করবে, টিস্যু থেকে কোলেস্টেরলগুলোকে নিয়ে এসে লিভারে গিয়ে ঢালবে। সো ইট ইজ বেনিফিশিয়াল অ্যান্ড ইট ইজ গুড কোলেস্টেরল। এবার একটু HDLটা একটু বলে দিই। HDLটা কি করে ফর্মেশন হয়? How HDL is formed? HDL ফর্ম হচ্ছে কিন্তু লিভার এবং ইন্টেস্টাইন দুটো জায়গায়। যেমন কাইলোমাইক্রন জন্য ইন্টেস্টাইনে ফর্ম হতো আর VLDL ফর্ম হতো শুধু লিভারে। HDL কিন্তু বোথ লিভার এবং ইন্টেস্টাইন দুটো জায়গাতেই ফর্ম করে। বোথ লিভার আর ইন্টেস্টাইন দুটো জায়গাতেই কিন্তু HDL ফর্ম করবে। লিভার থেকেও আসতে পারবে, ইট ক্যান লিভার অরিজিন হতে পারে, আবার ইন্টেস্টাইনে অরিজিন হতে পারে, আসতে পারে। এবং প্রথমত যে শেপটা থাকে সেই শেপটা হচ্ছে গেট স্কয়ার, এইরকম শেপ, ঠিক গোল গোল থাকবে না। ওগুলো যেমন গোল গোল ছিল, এগুলো কিন্তু গোল গোল হবে না। এগুলো কি দিয়ে তৈরি? মেজর লিপিড কি বলেছি? মেজর লিপিড হচ্ছে গিয়ে ফসফোলিপিড। মেজর লিপিড হচ্ছে ফসফোলিপিড। তাহলে কি কোলেস্টেরল থাকে না? কোলেস্টেরল থাকে। কোথায় থাকবে কোলেস্টেরল? সারফেসে। কোলেস্টেরল থাকে কিন্তু ওটা থাকবে সারফেসে। এবার নিচের একটা ব্যবস্থা করেছে ওই কোলেস্টেরল যেটা সারফেসের কোলেস্টেরলকে ভিতরে পাঠানো, নিচের একটা ব্যবস্থা করেছে সারফেসের কোলেস্টেরল যাতে ভিতরে চলে যায়। সেটা কি করে যাবে? সারফেসের কোলেস্টেরলকে যদি আমি ইনসাইডে পাঠাতে হয়, তাহলে একটা কাজ করতে হবে, কোলেস্টেরলটাকে স্টারিফাই করতে হবে। আমি যদি কোলেস্টেরলটাকে স্টার ফর্মেশন করতে পারি তাহলে কিন্তু ভিতরে ঢুকে যাবে সারফেস থেকে। এই কাজটা খুব ইম্পর্টেন্ট কাজ, কারণ এইচডিএল অন্যান্য টিস্যু থেকে কোলেস্টেরলকে টেনে নিয়ে আসে, কোলেস্টেরলকে টেনে নিয়ে এসে ও ভেতরে ঢুকে দেয় ইন দ্য ফর্ম অফ কোলেস্টেরল স্টার। কি করে স্টারটা হয়? হাউ কোলেস্টেরল ইজ কনভার্টেড টু কোলেস্টেরল স্টার? ইট রিকোয়ার্স অ্যান এনজাইম, and that enzyme is called LCAT. It requires an enzyme. এই জন্য এই একটা এনজাইম থাকে LCAT, ওটা যেমন LPA যেমন লাইসেস ছিল আগে, this is activated by A1 activates LCAT. LCAT means lecithin, C means cholesterol, A means acai, T means transferase. এর কাজটা কি হচ্ছে? লেসিথিন কি জানো তো? লেসিথিন শুনেছো তো? ফসফোলিপিড। ফসফোলিপিড থাকে তো? ফ্যাটি অ্যাসিড থাকবে তো? ফ্যাটি অ্যাসিড থাকবে ফসফোলিপিডে? কটা ফ্যাটি অ্যাসিড থাকে? হাউ মেনি ফ্যাটি অ্যাসিডস আর প্রেজেন্ট ইন দ্য ফসফোলিপিড? তিনটে নয়। তিনটে কি করে থাকবে? তাহলে ফসফেটটা কোথায় থাকবে? দুটো। তিনটে থাকে ট্রাইগ্লিসারাইড। তো বেসিক জিনিসটা ভুলে যাচ্ছ। This is glycerol. এবার তিনটে যদি স্টারিফিকেশন হয় তখন কি হবে? তখন এটা একটা ফ্যাটি অ্যাসিড, এটা একটা ফ্যাটি অ্যাসিড, এটা একটা ফ্যাটি অ্যাসিড। এটা কি হলো? এটা হচ্ছে ট্রাইগ্লিসারাইড। কিন্তু 1 নম্বর 2 নম্বর স্টারিফিকেশন আছে, কিন্তু 2 নম্বর 3 নম্বর ওই গ্রুপ ইজ স্টারিফাইড উইথ ফসফরিক অ্যাসিড, তখন সেটা হবে ফসফোলিপিড। এটা X বিভিন্ন সাবস্টেন্স কোলিন যদি হয় তাহলে ফসফ্যাটিডিল কোলিন, যেটা লেসিথিনে থাকে। সেরিন যদি থাকে তাহলে হবে ফসফ্যাটিডিল সেরিন। ইথানল অ্যামিন যদি থাকে সেটা হবে ফসফ্যাটিডিল ইথানল অ্যামিন। আইনোসিটোন যদি থাকে সেটা হবে ফসফ্যাটিডিল আইনোসিটোন। These are the phospholipids. These are the phospholipids. তাহলে ফসফোলিপিডস এর কতগুলো থাকবে? দুটো ফ্যাটি অ্যাসিড, দুটো ফ্যাটি অ্যাসিড থাকে স্টারিফাইড ফর্মে। এই একটা ফ্যাটি অ্যাসিডকে সরতে হবে, একটা ফ্যাটি অ্যাসিডটা সরে কোথায় যাবে? কোলেস্টেরলের উপর। সেই কাজটা করবে LCAT। ধরো এখানে কোলিন আছে, লেসিথিন মানে হচ্ছে যে এটা হবে কোলিন। তাহলে এটা হবে লেসিথিন। তো যখন কোলিন containing phospholipid, that is the lecithin plus cholesterol is equal to একটা 2 নম্বর ফ্যাটি অ্যাসিডে চলে আসবে কোলেস্টেরলের কাছে, দিয়ে লেসিথিন যদি একটা ফ্যাটি অ্যাসিড যদি ডিভয়েড হয় তখন সেটা নাম হবে লাইসোলেসিথিন। কোলেস্টেরল হয়ে যাবে কোলেস্টেরল এস্টার। ফ্যাটি অ্যাসিড এই 2 নম্বর ফ্যাটি অ্যাসিডটা চলে যাবে কোলেস্টেরলের গায়ে এবং কোলেস্টেরল becomes কোলেস্টেরল এস্টার। আর লেসিথিন after being deprived of one fatty acid it will be lysolecithin. This is the function of the LCAT. Lecithin plus cholesterol plus is equal to lysolecithin plus cholesterol ester. এই কোলেস্টেরল এস্টার হওয়ার সুবিধা কি হলো? ভেতরে চলে গেল। এবার HDL করছি কি? HDL করছি কি এই রিঅ্যাকশনটা বুঝে দিচ্ছি। HDL করছি কি বিভিন্ন টিস্যু থেকে কোলেস্টেরলগুলো টানছে সিনথেসিস হওয়ার পর, বিভিন্ন টিস্যু থেকে কোলেস্টেরলটা টানছে। অনেক টিস্যু আছে যেখানে কোলেস্টেরল জমে আছে, ব্লাড ভেসেল, এখান থেকে কোলেস্টেরলটা টানছে। কোলেস্টেরলটা টানছে and that cholesterol is converted to cholesterol স্টার, তাহলে প্রথম কোলেস্ট্রল এসে কিন্তু বাইরে থাকবে। এলকাটা তো বাইরে আছে, এলকাটা আছে প্লাজমায়, ও তো ভেতরে নাই। তাহলে কোলেস্ট্রল স্টারটা বাইরে হতে হবে, কিন্তু যে একবার কোলেস্ট্রল স্টার কনভার্ট হয়ে গেল তখন কিন্তু আর বাইরে থাকবে না, কোলেস্ট্রল স্টারটা ভেতরে চলে যাবে। এবার যত বেশি কোলেস্টেরল কনভার্ট হয় কোলেস্ট্রল স্টারে এবং তত বেশি কোলেস্ট্রল স্টার যদি ভেতরে যায় তখন ওর শেপটা কিন্তু পাল্টে যাবে, তখন শেপটা হয়ে যাবে স্ফেরিক্যাল, তখন শেপটা স্ফেরিক্যাল হয়ে যাবে। যখন এটা ফসফোলিপিড রিচ থাকছে এবং কোলেস্টেরল এন্ড ফসফোলিপিড রিচ থাকছে, নেসেন্ট এইচডিএল যেটাকে আমরা বলছি, নেসেন্ট এইচডিএল ইজ দ্য স্ফেরিক্যাল, কি শেপ বললাম এটাকে আমি? ডিস্কয়েড শেপ। এই ডিস্কয়েড শেপ হচ্ছে কি নেসেন্ট, তার কারণ কোলেস্টেরলটা কোলেস্টেরল হিসেবেই থেকে যায়। কিন্তু কোলেস্টেরল যত কোলেস্টেরল টিস্যু থেকে টানবে এবং যত কোলেস্টেরল স্টার কনভার্ট হবে তত কোলেস্টেরল স্টারটা ভেতরে চলে যাবে এবং ডিস্কয়েড শেপটা আস্তে 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 গোল হয়ে যাবে, স্ফেরিক্যাল হয়ে যাবে। তাহলে এটা আস্তে আস্তে স্ফেরিক্যাল হয়ে যাবে, স্ফেরিক্যাল হয়ে যাবে এবং এখানে যেমন ফসফোলিপিড এবং কোলেস্টেরল ছিল এটা হয়ে যাবে কোলেস্টেরল স্টার। কোলেস্টেরল স্টার এবং ফসফোলিপিড দুটোই থাকবে। তাহলে এটা হচ্ছে গিয়ে এইচডিএল, এটা হচ্ছে স্ফেরিক্যাল, আর এটা হচ্ছে ডিস্কয়েড। কেন ডিস্কয়েড আর কেন স্ফেরিক্যাল বললাম? কোলেস্টেরল স্টার কনভার্ট হয়ে গেল, এরপর ফেট হচ্ছে গিয়ে এটা লিভারে চলে যাবে। তাহলে টিস্যু থেকে কোলেস্টেরল টানছে, কোলেস্টেরল স্টারে কনভার্ট হচ্ছে, কোলেস্টেরল স্টারটা সারফেস থেকে ভেতরে চলে যাচ্ছে, ভেতরে চলে গিয়ে ওটা ডিস্কয়েডটা স্ফেরিক্যাল কনভার্ট হচ্ছে এবং স্ফেরিক্যাল হওয়ার পর ড্রন বাই দ্য লিভার, এইটা আবার লিভারে চলে যাবে থ্রু রিসেপ্টর। তাহলে লিভার টু লিভার, ওর সার্কেলটা হচ্ছে লিভার টু লিভার। হ্যাঁ, লিভার থেকে ও তৈরি হচ্ছে, কিংবা ইন্টেস্টাইন থেকেও যদি তৈরি হয় তারও ফ্যাট কিন্তু আলটিমেটলি লিভারে, লিভার থেকে যে তৈরি হয় তারও ফ্যাট লিভারে, ইন্টেস্টাইন থেকে যে তৈরি হয় তারও ফ্যাট লিভারে। তাহলে ও লিভার থেকে ও আলটিমেটলি লিভারে চলে যাচ্ছে। মাঝখানে যে কাজটা করছে টিস্যু থেকে বা বিভিন্ন অর্গান থেকে যেখানে কোলেস্টেরল বেশি জমে আছে সেখান থেকে কোলেস্টেরলটা টানছে, তিনি ওটাকে ভেতরে ঢোকাচ্ছে ইন দ্য স্টেরিফাইড ফর্ম and that is ultimately taken up by the liver, but this is called uric acid. This is called reverse cholesterol transport. So why HDL is beneficial? This is for reverse cholesterol transport. HDL is beneficial and the কত HDL থাকতে হবে আমাদের? যদি বলা হয় কত HDL থাকতে হবে, কত কোলেস্টেরল থাকতে হবে, আমি আমাদের প্রবলেম কতটা মিনিমাম এইচডিএল থাকতে হবে আর কতটা ম্যাক্সিমাম এইচডিএল থাকতে হবে ফর হেলথ, আমরা এটাই বলি। আমরা ম্যাক্সিমাম এইচডিএল আমরা পারমিট করি ফর নরমাল হেলথ, দ্যাট ইজ 100 হচ্ছে কি ম্যাক্সিমাম এইচডিএল। তারপরে যদি হয় এইচডিএল তাহলে রিস্কটা বেড়ে যাবে, আর্টারি ডিজিজ, করোনারি আর্টারি ডিজিজের রিস্কটা বেড়ে যাবে। তাহলে এইচডিএল এর লেভেলস অফ লিপিড প্রোফাইলটা কিরকম হবে? ডিজায়ারেবল লেভেল, এটাকে বলছি নরমাল লেভেল কিন্তু বলি না আমরা, ডিজায়ারেবল লেভেল। ডিজায়ারেবল লেভেলস অফ লিপিড প্রোফাইল কি কি হতে পারে? ইন কেস অফ কোলেস্টেরল, কোলেস্টেরল যদি হয় সেটা কোলেস্টেরল সেটা হবে below 200 মিলিগ্রাম পার কেজি, মানে কখনোই 200 এর উপর উঠতে দেওয়া উচিত হবে না। ডিজায়ারেবল লেভেল মানে বাঞ্ছনীয় লেভেল হচ্ছে গিয়ে less than 200 মিলিগ্রাম পার কেজি। এটাকে নরমাল লেভেল বলি না আমরা, ইন কেস অফ গ্লুকোজ আমরা নরমাল লেভেল বলি, ইন কেস অফ ইউরিয়া আমরা একটা নরমাল লেভেল টার্মটা ব্যবহার করি, বাট ইন কেস অফ লিপিড প্রোফাইল we use the term desirable level. Desirable level means it should be below 200 LDL should be 100 milligram per kg HDL should be এখানে কিন্তু minimum 40 milligram per DL or done to prevent coronary artery disease. For case HDL, আমাদের desirable level is that it should be minimum 40 or more. ওটা যেমন আমরা 100 or less, কারণ ওটা ডেঞ্জারাস, ওটা ব্যাড, ওটা যত কম থাকে ততই ভালো। HDL গুড, এটা যত বেশি থাকে ততই ভালো। তাহলে it should be minimum 40 as it is better if it is above 40 in case of HDL. In case of VLDL, there is no level. VLDL is actually measurement of the triglyceride. কিরকম? VLDL হচ্ছে গিয়ে VLDL কোলেস্টেরল হচ্ছে গিয়ে ট্রাইগ্লিসারাইড লেভেলকে যদি 5 দিয়ে ভাগ করি সেটা হচ্ছে গিয়ে VLDL। আলাদা করে VLDL মাপার কোনো আমার দরকার হয় না। আমরা যদি ট্রাইগ্লিসারাইড মাপি তাহলে ট্রাইগ্লিসারাইড বলে নিতে হবে। ট্রাইগ্লিসারাইড কত হবে? ট্রাইগ্লিসারাইডের লেভেল কত হওয়া দরকার? It should be within 150 milligram per DL. এই লেভেলগুলো একটু মনে রাখবেন। ট্রাইগ্লিসারাইড হবে within 150, কোলেস্টেরল হবে within 200, LDL হবে within 100, তার থেকে কম হলে ভালো। HDL হওয়া চাই 40 or above. This is the normal criteria for health. But disease হলে পরে কোলেস্টেরল 300, 400, 500 হতে পারে। ঘটনাটা কত সপ্তাহ হাইপার কোলেস্টেরোলিমিয়া, ডাক্তাররা কোন কোন কারণে কোন কোন রোগ দেখলে পরে কোলেস্টেরল লেভেল মাপে, কোন কোন রোগ দেখলে পরে কোলেস্টেরল লেভেল মাপে। কার্ডিওভাস্কুলার ডিজিজের জন্য সে একটা মাপে। এবার কার্ডিওভাস্কুলার ডিজিজ আছে অথচ কোলেস্টেরল নরমাল, এরকম আমরা হামেশাই দেখতে পাই। কার্ডিওভাস্কুলার ডিজিজের একটা ফ্যাক্টরের জন্য শুধু হয় না, ইট ইজ নট দ্য সিঙ্গেল ফ্যাক্টর, ইট ইজ আ মাল্টি ফ্যাক্টরিয়াল ব্যাপার। Cholesterol, increased cholesterol is one of the factors. There are many other factors of the coronary artery disease, like smoking, like alcohol, like family history. যদি কারো ফ্যামিলি হিস্ট্রি থাকে হার্ট ডিজিজের, প্রিমেচিওর আগে যদি মারা যায়, অনেক ফ্যামিলিতে হিস্ট্রি থাকে যেটা 50 এর উপর কয়েকটা বাঁচে না, তারা 50 এর উপর 50 এর মধ্যেই মারা যায়। there are many families, সেক্ষেত্রে ওটা রান করে ফ্যামিলিতে। হ্যাঁ, সেগুলো যদি থাকে তার রিস্কটা কিন্তু অনেক বেশি। ফ্যামিলি হিস্ট্রি যদি থাকে, স্মোকিং যদি থাকে, ডায়াবেটিস যদি থাকে, হ্যাঁ, এবার মেল পারসন দিতে হয়। মেলেদের রিস্ক বেশি ফিমেলদের থেকে। ফিমেলদের ইস্ট্রোজেন কোলেস্টেরলকে প্রোটেক্ট করে, ফিমেল হরমোনস প্রোটেক্টস কার্ডিওভাস্কুলার ডিজিজ, কিন্তু মেলেদের ইস্ট্রোজেন নেই, সুতরাং মেলেরা প্রোটেক্টেড নয়। মেলেরা ইজ মাচ মোর প্রোন to cardiac attack than female, because men do not possess estrogen progesterone, female possess estrogen progesterone, which is beneficial for cardiac health. একটা ডিজিজ রান করে ফ্যামিলিতে, যাকে বলি ফ্যামিলিয়াল হাইপারকোলেস্টেরোলিমিয়া। Familial hypercholesterolemia. Familial hypercholesterolemia. এই টার্মটা আমি শুনে রাখো। Familial এখানে কোলেস্টেরল বাড়বে। কোথায় কোলেস্টেরল বাড়ছে তার মধ্যে একটা ইম্পর্টেন্ট কারণ হচ্ছে গিয়ে ফ্যামিলিয়াল হাইপারকোলেস্টেরোলিমিয়া। এরা বেশিরভাগই মারা যায় অল্প বয়সে, এরা ফ্যামিলিতে রান করে। কারণটা কি? এদের কোলেস্টেরলটা বেশি হয় কেন? এদের কোলেস্টেরল বেশি হওয়ার কারণ তো থাকবে একটা। কারণ হচ্ছে গিয়ে এদের এলডিএল রিসেপ্টরটা ঠিক মতো তৈরি হয়, মানে এলডিএল রিসেপ্টর যেটা লিভারে থাকে, এলডিএল রিসেপ্টর ইজ ডিফেক্টিভ। There is a mutation of the LDL receptor. ডিফেক্টিভ এলডিএল রিসেপ্টর হলে কি হবে কি এলডিএল এর যে কোলেস্টেরল আছে সেই কোলেস্টেরলের দুটো ফেট আমি বলেছি একটা লিভারে চলে যাবে আর একটা টিস্যুতে চলে যাবে এবার লিভারে তো যেতেই পারবে না লিভারে সে যাবেই না যাবে কোথায় এলডিএল এর সিঙ্গেল ফেট হবে that fat is the that will be cholesterol will be goes to the tissues সেই জন্য কোলেস্টেরলটা বেশি থাকে এতে বিকজ অফ এলডিএল রিসেপ্টর ডিফেক্ট আর কি কারণ হতে পারে দুই নম্বর হচ্ছে ডায়াবেটিস মেলাইটাস যদি কারো ডায়াবেটিস থাকে তাহলে হাইপার কোলেস্টেরমিয়া হবে মেকানিজম আছে হাইপোথাইরয়েডিজম যদি তার টিএসসি বেশি থাকে টি3 যদি লো হয় সেক্ষেত্রে কোলেস্টেরল বাড়বে একটা জন্ডিসে বাড়বে obstructive jaundice these are the causes of the hypercholesterolemia these are the causes of the hypercholesterolemia diabetes থাকলে বাড়বে obstructive jaundice থাকলে বাড়বে hypothyroidism বলে বলবে আর একটা ফ্যামিলিয়াল কজ এ বাড়বে হ্যাঁ এই কারণগুলো একটু মোটামুটি জানা যায় প্র্যাকটিস করতে গেলে বা আপনি পরীক্ষায় পাস করতে গেলে জানা দরকার ওকে লাইপোপ্রোটিন ডিসঅর্ডার আছে অনেকগুলো কিন্তু আমি বললাম না আমি ওগুলো অনেক ভারী হয়ে যাবে এই যে কথাগুলো বললাম এই কথাগুলো এইগুলো ভাইবাতে অনেক কিছু
We had been studying various aspects of the nervous system for the past few weeks. We almost completed spinal cord. The last day of the spinal cord is today, when we will discuss lesions of the spinal cord or diseases of the spinal cord. Of that, one we already had some talk, and that is the complete transection of the spinal cord. If the spinal cord is cut off completely through and through, what will happen? We all talked in 3 stages, stage of spinal shock, etc., etc. So today, the second topic, that is Brown-Sequard syndrome. These diseases of the spinal cord or lesions of the spinal cord, complete transection of the spinal cord, number 1, hemisection, half of the spinal cord is transected, other half is left intact. This is called Brown-Sequard syndrome. Number 3 is syringomyelia. And number 4 is tabes dorsalis. Just 4 items. Complete transection of the spinal cord we already discussed. Brown-Sequard syndrome, number 2. Syringomyelia, number 3. And tabes dorsalis. It is not true that these diseases are very common. But it is also true that these diseases are not uncommon. We will find, once in a while we will find these types of conditions in your life, and then you will have to tackle it. If you know it beforehand, it will be easier for you to understand them. But somehow or other, I don't know the reason, but for many years I have been seeing that every year without exception, at least one of these will come in your exam, either in the main question or in the explanation question or in the short note section. In one of them, only 4 diseases: spinal cord, complete section of the spinal cord, Brown-Séquard syndrome, syringomyelia, tabes dorsalis. One of them will be present in your question paper every year without exception. I don't know why. Now this Brown-Séquard syndrome, don't think it is a hypothetical situation. Don't think it is a imaginary or theoretical disease. No, it may be there. This very often happens in case of, in later life I knew, when I was a student I didn't know that. Even I thought these are all hypothetical diseases. Only for exams we have to study. One very common cause of these diseases is, this disease, Brown-Séquard syndrome, is automobile accident. Automobile accident. With the, in older days when we were just doctors, we did not know actually what is a CT scan, what is MRI scan, etc., etc. But nowadays with the advent of diagnostic technology, we all know exactly what has happened. Previously what we did, we could do at the most, we could do an X-ray of the vertebral column. Yes, C7 is broken or T10, 10th thoracic vertebra is broken. That's all. X-ray we will know only the bony injury. What happens to the spinal cord, what happens to the bone, to the brain, we never knew. And that we had to understand, we had to know only from clinical features. So in those days, clinical features, understanding physiology was very, very important. I remember not very long ago, so 1 or 2 years ago, at the most 2 years ago, I went to a relative's house. So he had some problem. Problem means very acute problem, sudden. So I saw him, examined him, because somehow I went there and I said, it is a case of severe cerebral stroke, probably the location is this, etc., etc. They all listened to me, I prescribed, they started the medicine also, and the same day they went for CT scan, and the report came after several hours. When the report came, they rang me up, the report has come, this is a case of stroke only, this part of the brain has undergone this thrombosis, infarction, etc., etc. And the lady, the patient's wife, she asked me, I want to ask you a question. He said, what? So without doing CT scan, just after seeing the patient, you said, he has stroke, you gave the medicines, you said probably this is where the lesion is. How did you do that? I said, then why did I do the clinical examination? Do you think these are all useless? Only CT scan can tell this is the disease, otherwise before that patient will get no treatment. So after 1 day the CT scan will be done, report will come, even 12 hours later than that, then the patient will start treatment, and the treatment will be failure because the golden initial 6 hours already lost. So this should not be the case, and that is why you should know the theoretical things, the clinical features, clinical things. What is another name for Brown-Séquard syndrome? Hemisection of the spinal cord. hemisection of the spinal cord, this is a cross section of the spinal cord, this is the grey matter, this is the central canal, this is all white matter. Hemisection means this part is, you take a blade, cut it of this, like this. Say this side is intact, this side is having a lesion, an injury, a damage. As you understand, whether you are riding a motorcycle or you are riding a car or even bicycle or you fall from a height, all these things may lead to hemisection of the spinal cord and rarely complete section of the spinal cord. And when it is hemisection of the spinal cord, then we call it Brown-Sequard syndrome. Now what are the features? As I said, remember the features. In neurology, one thing, treatment is very poor, very poor still now. But anyway, science is advancing and treatment will come up. When you will be a little bit older, lots of treatment will come up and you can treat most of the diseases. Now, but the thing is, one good thing about this is, unlike any other system, whether it is gastroenterology or nephrology or hematology, treatment is very good there. But here, treatment is not good, but diagnosis, clinical diagnosis is excellent if you can do it. You can make a pinpoint diagnosis which you later on corroborate by the help of CT scan, MRI scan, etc. Study the clinical features. Clinical features above the level of knee. Say it is in the T10, 10th thoracic level of the vertebra. The part of the spinal cord at the level of the 10th thoracic vertebra. Maybe there is fracture of the 10th thoracic vertebra. And the spinal cord there has got a lesion like that, and half of the spinal cord is torn at this level, T10. So what will happen above the T10 level in the body? Not much. But a few centimeters above the level of lesion, if it is T10, above T10, there will be a band of hyperesthesia. What is hyperesthesia? Excessive sensation. See, if you touch a pin, needle, you will feel the pinpoint. Every day you are feeling the needle prick on your hand in the physiology laboratory. Are you? Hope you are. Maybe there are some clever boys who don't prick themselves, they prick others, and not so clever boys, they get pricked more. Whatever it may be, you feel. But sometimes some people are highly touchy. Even if you haven't just touched it, as if something severe injury has been there. So this is called hyperesthesia, excessive sensation. When the sensation, the feeling is much greater than what it should have been, then it is called hyperesthesia. When it is less than normal, less pain than what you should have felt, then it is hypoesthesia. No sensation at all. Even if you put a dagger, you won't feel pain. Then it is anesthesia. In an anesthetized person, you can put a needle, not only needle, even a knife, anywhere in your body, the patient will not complain. Even if he is not dead, he is only anesthetized. So if you have anesthesia, no sensation, no feeling of pain. By anesthesia or anything, we mainly mean pain. If it is more than normal pain, it is hyperesthesia. So above the level of lesion, if the lesion is at T10, a little, say 2 centimeters or so in a small band in the body above the level of T10, you will get hyperesthesia, more than normal sensation. That's all, on both sides, this side, that side. It doesn't matter whether it has happened in the right side or the left side. Now, that is above the level of, what happens at the level of lesion, at the level of T10, on the same half, lesion has been here. This is left side, this is right side, this is posterior, this is anterior. So if it is on the left side, above, over, both sides hyperesthesia, only up to a small band. At the level of lesion, on the same half, on the left side, you will find two things: complete sensory loss on the same side where the lesion has been, that is left side. Complete sensory loss. Complete sensory loss on the left side. That means the side which is affected. Don't in the answer book say left side, that side, because I am telling if the left side is affected, on the affected side you will write in your answer book. You know, you are cleverer than me. Anyway, complete sensory loss and lower motor neuron type of motor loss. Lower motor neuron type of motor loss. We are discussing about at the level of lesion, at the T10 level. Opposite side, right side, at that level of lesion, at the T10 level, only pain, temperature and crude touch lost. Pain lost, main thing pain, temperature, warmth sensation, cold sensation lost, pain, temperature and crude touch. You know, touch sensation may be of three types: crude touch and fine touch. So two types: fine touch, another two: tactile localization, where it is touched, and tactile discrimination, 1 point or 2 point. Tactile discrimination, only a few weeks later you will be having physiology practical and practical examination of the nervous system, neurophysiology practical, and there you will all do tactile discrimination and tactile localization. Now this is fine touch, tactile discrimination, localization, fine touch, and it is touched or not, it is crude touch. When you touch, this is called crude touch. When you touch with a fine cotton wool, it is fine touch, very delicate touch. So above the lesion, over, at the lesion, at the level of lesion, below the level of lesion. Below the level of lesion is very important. That means below, we said the lesion has been on the 10th thoracic vertebra. So below that, 9th, 8th, that is above, and 11th, 12th, or lumbar 1, 2, 3, 4, 5, sacral, etc. All are below that. So below that level, that is the most important thing, because it is a larger area. At the level of area is very small area. Above the level of lesion, nothing much, only a band of hyperesthesia. Band means only a few centimeters, maybe 2 or 3, not more than that. Same side, you all divide same side and opposite side. Same side means where the side where the lesion has happened. Opposite side opposite to the side where the lesion has happened. On the same side, motor, upper motor neuron type of features. There will be paralysis. What type of paralysis? Upper motor neuron type of paralysis below the side of lesion. Sensory, loss of fine sensations, fine touch, joint sensation, vibration sensation. Fine touch, that means tactile localization, tactile discrimination, touch with a piece of cotton wool, very fine piece of cotton wool, not touch like this. That is lost, but crude touch is not lost. Pain retained, temperature sensation retained. Three most important means most prominent sensations are pain, temperature, heat, cold, etc. and crude touch. These are the three most prominent sensations. These are carried by the lateral spinothalamic tract. So these are on the same side, these are retained, no loss, but finer sensations are lost, that means vibration sensation, joint sensation, fine touch, etc. This is the motor effect, upper motor neuron type of paralysis. Sensory effect, loss of fine sensations, whereas crude sensations are retained. Opposite side, motor effect practically nil, very slight motor effect may be there. Sensory effect is remarkable. Why it is called remarkable? Because there is loss of pain, loss of, if you put a pain finger prick, you won't feel anything. Loss of temperature, loss of heat, loss of cold. If you put a ice cube, patient will not be able to say it is cold ice. No pain, no ice, no heat. These will not be understood. And also crude sensation. Can you feel the touch? No. So, loss is remarkable, sensory loss is remarkable because the three main sensations are lost on the opposite side, below the level of lesion. So that's all. But fine sensations are retained. Now why this? Crude sensations are lost, fine sensations are retained, or on the same side, fine sensations are retained, lost. Crude sensation. Why? Because fine sensations are carried by the posterior column, tract of Gall and tract of Budak, or fasciculus gracilis and fasciculus cuneatus. So these carry the fine sensations. Fine include fine touch, vibration sense, joint sense, etc. These are through the all sensory fibers are passed into the spinal cord through the dorsal root. You know there is one ventral root and a dorsal root. They enter the spinal cord, all sensations through the dorsal root. And ventral root, motor sensations go away from the spinal cord. Motor impulses go away from the spinal cord to muscles through the anterior tract, through the posterior tract, this is the anterior, this is the posterior, all sensory through the posterior. Oh sorry, this is anterior and this is posterior. Say all sensory, anterior, all motor. The moment they enter the spinal cord, the fibers which carry crude sensations like crude touch, pain, temperature, they immediately move to the opposite side. From the left they enter, they go to the right, then they go upwards through the lateral spinothalamic tract, through the lateral spinothalamic tract. If you cut the lateral spinothalamic tract, no pain sensation, no temperature sensation. Is it making sense? So what do you get? If there is a hemisection of the spinal cord, above the lesion, above the site of lesion, at the level of the lesion, below the level of the lesion, above the level of the lesion, same side, complete sensory loss, and lower motor neuron type of motor loss. Opposite side, pain, temperature, crude touch lost because they go to the opposite side, these fibers. Immediately after entry to the spinal cord, they go to the opposite side. Left side sensation fibers go to the right side. Right side sensation fibers immediately will go to the left side. So above the lesion, at the level of lesion, same side, upper motor neuron feature, sensory effects, loss of fine touch, joint sensation, vibration sensation. But crude sensations are retained because they are not present on the same side, they go to the opposite side. Now, you may be wondering, I don't know whether you are wondering or you know, what is upper motor neuron lesion and what is lower motor neuron lesion? Do you know it? Better write a chart. What is the difference between an upper motor neuron lesion and motor fibers in the spinal cord? There are motor fibers, motor tracts and sensory fibers or sensory tracts. On the beginning, from the very first day, I have been talking about these are the motor tracts, like the spinothalamic tract, anterior spinothalamic tract, lateral spinothalamic tract, posterior column, tract of Gall and tract of Budak, better called fasciculus gracilis and fasciculus cuneatus. These are all sensory tracts. Motor, corticospinal fibers, those which are coming from cerebral cortex or from anywhere from the brain coming downwards, they are all motor fibers. These are all called motor tracts. When a bundle of fibers form a tract, they are called motor tracts. So, if there is a lesion of the motor tract anywhere in the body, if you cut the spinal cord, definitely there will be lesion of both sensory tracts and motor tracts. But we are now talking about motor tracts. If there is a lesion of the motor tract, it may be upper motor neuron or lower motor neuron. But what is upper motor neuron or what is lower motor neuron? Upper motor neuron means upper motor neuron lesion, better called. Upper motor neuron lesion means any lesion, any injury involving the anterior horn cell and above. In a motor tract, you know at every segment of the spinal cord, the anterior horn cell, posterior horn cell, all motor nuclei are in the anterior horns. So, cells in the anterior horn are motor nuclei. From there fibers go to the different muscles and help in the movement of different muscles. They maintain the tone of the different muscles. All movements coming from the anterior horn cells. These are, in other words, they are also called motor neurons. Some of the motor neurons are not present in the spinal cord. Some of the motor neurons are from the brain, usually from the brain stem. Like oculomotor nerve is a motor nerve, but its neuron is not in the spinal cord, but in the medulla oblongata, in the brain stem. A trochlear nerve, trigeminal nerve, in the brain stem, then neuron, motor neuron in the brain stem. So, above the anterior horn cell or the cranial nerve motor neuron, anywhere the lesion may be, from the brain, starting from the brain to the spinal cord, anywhere the lesion may be, the injury may be, it will be upper motor neuron type of lesion. Below that level, it will be upper motor neuron type of lesion, and the paralysis will be upper motor neuron type of paralysis. And if it involves the anterior horn cell and below, either in the anterior horn cell or below it, then it is lower motor neuron type of lesion. So, number one is above anterior horn cell. The lesion is above the anterior horn cell. Lesion is at or below anterior horn cell. That is the difference in definition. Upper motor neuron lesion, by definition, it means any lesion above the anterior horn cell of the spinal cord is called upper motor neuron type of lesion. Any lesion at or below the anterior horn cell is lower motor neuron type of lesion. There is paralysis, spastic type of paralysis. This is called, in lower motor neuron lesion, flaccid type of paralysis. Was it the function of biceps? Flexion of the elbow. Many functions. Most important among them is flexion of the elbow. Supination also. What is the function of the triceps? Extension of the elbow. If we cut the nerve supplying the biceps or the triceps, it will be lower motor neuron much below the anterior horn cell. We cut the nerve, it is lower motor. What type of paralysis it will be? Flexion. The muscle will be flaccid. It is lower motor neuron type of lesion. If you touch it, muscle will be very soft. If you fold, it will be like this. Very easily it flexes, and because it is paralyzed. Very easily you can flex it, very easily you can extend it. The muscles are not giving any inhibition. So, in lower motor neuron it is flaccid paralysis. And what is spastic paralysis? Here also there is paralysis. You can neither flex nor extend, because both the biceps and triceps are paralyzed. But it is not due to any damage to the nerves supplying the biceps or triceps. It is due to a damage above the anterior horn cell in the spinal cord. The motor tract in the spinal cord is cut off. It is the cortical coming from the cerebral cortex, that sensations are cut down, cut off. This is spastic paralysis. If you want to flex, you will have to struggle. If you want to extend, you will have to struggle. But it is paralyzed because the muscles are not working. But if you passively try to flex, you will have to struggle. You will feel lots of resistance. If you passively try to extend, you will feel lots of resistance. So, in upper motor neuron type of lesion, the very characteristic feature is upper motor neuron type of paralysis is a very classical feature of stroke. Stroke is when it has happened above, maybe at the brain stem, maybe in the brain proper, inside the cerebral hemisphere, or maybe in the spinal cord, but not in the nerves. So, spastic paralysis, opposite flaccid paralysis. I have already written. Number 3 point. If the leg muscles are paralyzed, the person, it is very difficult to make that person walk or do any leg movement like this, even in lying posture, but may be possible a little bit. But in case of lower motor type of lesion, no movement is possible at all. So, gross movement is difficult but may be present. In lower motor neuron, so this is difficult, but may be present. This is totally lost. If it is lower motor neural lesion, that means the lesion at the level of the anterior horn cell or below that. Number 4, Do you know deep reflex? Reflexes may be superficial reflex, reflexes may be deep. By deep reflex, we want to mean the jerks. Stroke here, the tendon, the patellar tendon, this is called knee jerk. The tendon of the calcaneus tendon, we call it ankle jerk. So knee jerk, ankle jerk, wrist jerk, biceps jerk, the biceps tendon, there will be movement like this. These are called jerks or tendon reflex or deep reflex. Deep reflexes in upper motor neuron lesion are exaggerated. Also called jerks. Deep reflexes in lower motor neuron, deep reflexes or jerks are lost, totally lost, no knee jerk, no ankle jerk, etc. In case of stroke, there is upper motor neuron lesion, there is exaggerated knee jerk, exaggerated ankle jerk, exaggerated biceps jerk, etc. But in lower motor neuron, no jerk or reflex in that area where the lesion has occurred, below that area. There is another that is called clonus. It is very prominent, very clear in case of ankle. What is clonus? Clonus means we will have to show it in the practical room, otherwise you will not fully understand. Say you take any hand and just jerk it like this, flex it like this, or you take the foot, flex with a jerk, you flex it, or take the patella with a jerk, you push it upwards. And you will find in case of this, it will move like this. In case of foot, it will keep moving like this. In case of patella, it will move up and down. This is called clonus. Move sometimes and then slowly it will wane off and stop. This is called clonus. In upper motor neuron lesion, clonus may be present. In lower motor neuron lesion, if there is lower motor neuron type of paralysis, no clonus business. Clonus cannot occur. No clonus. What about the muscle tone? In upper motor neuron, the muscle tone is grossly increased. Muscle tone is totally lost in lower motor neuron lesion. There is no question of muscle tone, it is absent. Now superficial reflex. If you just stroke with a needle or a say divider needle or pencil compass needle like this. The corresponding abdominal muscles will contract. Here corresponding the thigh muscles will contract. This is called superficial reflexes. Now what happens is superficial reflexes are absent or lost. This is the only one point, the point number 7, where the two type of lesions agree, same effect. In superficial reflexes, whether it is upper motor neuron, superficial reflexes are lost. Lower motor neuron, superficial reflexes are lost. In both cases, superficial reflexes are absent. Only in normal persons, superficial reflexes are present. After some lesion occurs, there will be degeneration and there will be some reactions of degeneration. In case of upper motor neuron, there is no reaction of degeneration. Absent. Present. Only in lower motor neuron lesion this is present. Then there is fasciculation. Muscles show very fine movements. This is called fasciculations. With the naked eye you can see some fasciculation movements of the muscles, spontaneous, without any stimulus from above. Some fasciculation movements. And fibrillation movements, these are called some fasciculation movements or fibrillation. Fibrillation means you don't see the movements of the muscles, but if you add an electromyograph and take a tracing, EMG, electromyogram tracing, that will show movements. The movements which are visible only in EMG, but never in naked eye, that is called fibrillation, and very feeble fine movements in the naked eye, that is called fasciculation. Now in upper motor neuron, no fasciculation, no fibrillation. In lower motor neuron lesion, in later phase, the fibrillations and fasciculations may be observed. no fasciculation or fibrillation of muscles. After a gap, after some days, after some time, some fibrillations and fasciculations are observed. This is at the end. So, we have talked about 9 points. Number 10 point is, in the upper motor neuron lesion, there may be muscle wasting, but very difficult to notice. That means muscle wasting is insignificant. Muscle wasting, loss of muscle mass, loss of muscle mass, thinning of the muscle mass, both the size and the weight of the muscles decrease. That is called muscle wasting, is insignificant, not very here is insignificant. Muscle wasting is notable. That means quite significant, is notable. In case of lower motor neuron, muscle wasting is much more severe and notable and significant. In upper motor, not significant. And last 11th point, you may add one more, though you won't find it everywhere, but only in case of lower limbs. If the lesion is in the lower limb, if the paralysis is in the lower limb, then only you will see it. That is plantar reflex. You scratch the lateral border of the under surface of the foot. In one word, sole. S-O-L is sole. You scratch that along the lateral border of the sole of the feet. You will find there is extension of the lateral 4 toes, second toe, third toe, fourth toe and little toe, fifth toe. Extension and fanning out of the, and also extension of the big toe. Extension of the big toe and fanning out of the other 4 toes. That is called Babinski sign. It is present, positive. No Babinski sign. What happens in normal person? In normal person, or in case of, in normal person there is flexion of all the 5 toes. Plantar flexion of all the 5 toes. This is, if these are toes, plantar flexion of all the 5 toes. And in upper motor neuron, dorsiflexion of all the 5 toes along with fanning. They move away from each other. Fanning and dorsiflexion of the, particularly the big toe, Budo Angul. This is called Babinski. Babinski is a Polish scientist. Polish means of Poland, belonging to Poland. Okay. What is the time now? 5:02. Can you spend some 10 minutes more? Anyway, there are two more diseases we have to study. One is syringomyelia. It is also a frequently asked question. Syringomyelia. What is syringomyelia? Syringomyelia is a disease of the spinal cord where the tissue around the central canal, you remember the picture, there is a central canal, the tissue surrounding the central canal is damaged, particularly the front and the lateral parts. Central. Only these tissues are damaged, particularly the one. This is called syringomyelia. What are the clinical features? Loss of whatever happens in syringomyelia is bilateral, not on the affected side, this side, left. Because this is a central phenomenon. Effects are always bilateral. What happens? Fine sensations like fine touch, vibration, joint fine sensations are retained and crude sensations like crude touch, pain and temperature, these are lost. This is called dissociation of sensation. Dissociation of sensation. This is called syringomyelia. This much is enough for syringomyelia. Then there is another disease called tabes dorsalis. Tabes dorsalis. Tabes means weakness or damage. Dorsalis means dorsal. That means dorsal horn cells, dorsal ganglia, all sensory fibers enter through the dorsal nerve root and they relay the synapse in the dorsal ganglia. These dorsal ganglia are damaged. Then it is called tabes dorsalis. Dorsalis means dorsal root ganglia. And tabes means weakness or damage. Principal cause of tabes dorsalis is syphilis, untreated syphilis when it goes to from the first stage to second stage, third to fourth stage. Fourth stage is called stage of neurosyphilis. That means the nervous system is involved. In that stage, in syphilis, the dorsal root ganglia are damaged. And then only tabes dorsalis occurs. What are the symptoms? Because they are sensory nerve roots, the sensory ganglia are damaged, so sensations are lost. So loss of not only pain, temperature, etc., but also loss of touch, vibration and joint sensation. Naturally there will be loss of muscle tone, loss of deep reflexes, and when two important things, stumping gait and rhombic sign, stumping gait sign. That means when the person will walk, he will walk like this. Did you follow? This is called stamping gait. Gait is not normal, stumping like this. Pulls up, then stamps the floor. Pulls up, stamps the floor. Pulls up, stamps, like that you will walk. That is called, you walk like that in the muddy areas, isn't it? Stamping sign, stamping gait sign. And second is rhomboid sign. Rhomboid sign is a very classical sign for tabes dorsalis. Ask the patient, slightly fold the knee joint, slightly, like this. Then close the eyes. What will happen? If there is tabes dorsalis, the person will move, will lose balance and will tend to fall. Usually the person falls. If there is some degree of classical tabes dorsalis, so when you ask the patient to show the rhomboid sign, always be there with your hands alert. If the patient really falls, you will have to catch him. If the rhomboid sign is negative, nothing will happen. If the rhomboid sign is positive, the patient will fall and may sustain injury, so you will have to catch the patient before falling. So this is called rhomboid sign. Then there will be atonic bladder, patient will not pass urine regularly, or patient will keep on passing urine. And if the patient wants to walk, eyes closed, he will be moving, stumbling, tendency for falling, that is called loss of balance and equilibrium when walking with eyes closed. And if you ask the patient, this is a straight line. If you ask the patient to walk in a straight line, he will not be able to walk. Now remember one important thing, don't think syphilis is a very old fashioned disease. It does not occur. Yes, but tabes dorsalis like symptoms can occur even today because of diabetic neuropathy. When in diabetes there is nerve damage, gross nerve damage, there is also damage of the dorsal root and dorsal root ganglia, leading to all symptoms of tabes dorsalis. That is rhomboid sign positive, stumping walk, gait and